Welcome everybody to Örebro, Sweden. This is what we call the EVTM, the Endovascular and Hybrid Trauma Management Workshop. First, I would like to say we call it workshop. It's not a course. The idea is not that we will teach. The idea is to share knowledge. That's why it's a joint platform. There are a lot of people involved in this, and we try to learn from each other in this platform how different people do. And I would like soon to present that everybody will present themselves with who they are, where do they come from. I would like first to present some people that we are working with, the group itself. First, I'm honored to present Thomas Larsson. Thomas is my mentor and has been dealing with endovascular technique for many, many years.
Since you were born.
And he and the other colleagues taught me everything I know. So it's a big honor for me. Arta Piratran, my colleague, great colleague, and a friend here. Asko Toivola is, maybe you should stand up, right? Sure. Asko is now in surgery. He will come later. Richard Lingen. Richard?
Yes.
He is my dear colleague, and he's responsible for the trauma in this hospital and in this region. Per Skog. He's our dear friend and colleague, vascular surgeon, also working now in Gothenburg in another hospital. We have also other colleagues, of course, they are not present here, and we will meet them later on. Yun from Japan. Here, Jun. Very experienced interventional radiologist, I guess you can say, with huge interest in emergency things. He will tell you about this stuff later on. Tomohiko is here, also from Japan. A colleague will help us also to share the views and experience. Martin Delle from Stockholm. Interventional radiologist, deals a lot with everything that has to do with bleeding, vascular things, and you can tell later on about it. Victor Reva, Victor from St. Petersburg, very engaged in all the Reboa works in the vascular and trauma surgery, and we've been working together, and it will be very nice to hear and see what you can do and help us. Then, of course, Johan, Monica, Jonas, Katarina, Nina, Christopher, and Mitra that are here. Maybe you can just raise your hand or stand up. Katarina Lindahl is our secretary that helped us in everything here, and the correspondence was with her. And the rest, they will present themselves later on. Christopher is our anesthesiologist and is working with us in a lot of projects. Johan and Jonas are working in the angio suite and hybrid suite. Monica is a vascular nurse, and Nina is our nurse, helps us a lot in the lab, and Mitra, which is a doctor, and she works, she's a PhD student. Of course, we have to say thank you so much for the industry that helps us. Without them, it's impossible to do these kind of things. And if I wrote the names right, they should be there. And of course, I have to put Toshiba in that they join us. And it's Siemens, Meliora, Takeda, Mentis, still Medtronic, and 3D Imprimo. There will be live feeds from here by association, a company in Stockholm. Doug will take care of it. So the plan is like this. I would speak shortly about the EVTM concept. It's a new concept, and some words about other projects and how we look at the whole thing. Then we'll speak about, Thomas will speak, do a short presentation from his experience. Arta will speak some minutes. The idea is that we present things and then try to open it for discussions and share the knowledge. And everybody are very welcome to feel that they can tell everything they want, say whatever you want. We should share the knowledge. Martin Della will speak later on, and then our Japanese friends, Jun, I guess, will speak. And then we'll speak, Victor will speak about Reboa. There are two names, ABO and Reboa. I will explain later on. It's a bit competitive names, but we use both right now. Then we will have a Skype talk with Joe DuBois. Joe DuBois is a trauma and vascular surgeon in the US, currently in California. We will have him on, and we have a list of things we will discuss with him. He's a great expert in the area, and he's conducting very big, huge works with this. And the idea is we discuss a bit, and we're very welcome to open question and speak to him. That's the whole idea. He will not give a lecture. Then we will have case discussions. I will try to hold the times. We will see, and I will do some modifications there. Discussions, and we have different cases. I would be very happy if you guys can take own cases. It can be a photo, it can be something simple, or just tell us something that you met and we can discuss. And the idea is, again, to discuss how can EVTM help, how modern methods can help in different situations. Nobody's forced to present anything, but I will be very happy if you can just show us things that you think are important. Then we will do the practical thing here. Again, it's people from different backgrounds and different, they know different things, but we will try to work like this. That we will work on two stations that are C-arm stations, or hybrid suite, I should call it. We will not use the C-arm here because then you need protection gear. We will use it tomorrow in the lab. But you can, it's good to see the machine. It will be open, and you can ask the company, of course, about it. The angio table, sliding table, you can use it. And this has a huge role in more than in EVTM, in modern trauma management as we see it. So you can test it, and there we'll work on Seldinger method, on puncture method, how to do it, tips and tricks, and how Martin, Artai, Per, Thomas, how they think, how they see it. If you see it in another way, if you like doing it in another way, tell us, and it's a great discussion point. We will put on the Reboa, the aortic balloon. We will use Tokai, a rescue balloon, which is a really amazing balloon that comes from Japan, and it's not yet in CE mark in Europe, but I hope it will be soon to be used, and we can use it here on the PICS. We will have also an ultrasound station where we should, the idea there for someone who wants to feel how it is to puncture, to do Seldinger method for these trauma things, how to feel that with ultrasound, how to use it. The idea is not to teach ultrasound in this short session. We will have also the Mentis. It's a great simulator that you can do Reboa, ABO Reboa, and you can also do embolization. And we will do rounds, and I will try to help you guys just to do these rounds, but feel free to feel if you feel you want to do something else. And the idea is, again, to share the knowledge, practice what you feel is important, and learn from each other in different aspects. We will try to be clear to 6:30, 6:45, and go together to Wobbler, to this restaurant, which is in the center of the city. It's around 12 minutes walk from here. It's a bit cold outside, so I hope we manage. If someone wants, we can check for, call for a taxi, but it's not a long walk, and it will be nice with fresh air, cold air. Two important things. The lunch today is courtesy of our friends from Takeda, and we want to thank them very much. And tonight the dinner is courtesy of our friends in Milio Medtech, and we want to thank Daniel. And thank you, and Matthias somewhere here also from Takeda. Okay. This is the way to go to the restaurant, and we will try to make it clear. I will take it up again before we go. Tomorrow we do like this. In order to have effective time, we will change to a surgical clothes here. It's only the doctors that can go not down to the pathology. So I'm sorry, but people from the industry are not allowed to be there. So I apologize, but this is how it is. We will change fast here, 7 o'clock, and we'd ask you to be on time because we will lose time if we can't start. And we go all together to the pathology department. We have one case there. The idea there is to discuss in front of a real body the scenarios, what can you do, what you cannot do, share experience, and see. It's so it's a lot of new things. What's possible, what can be done, what was never done. So the idea is not to do the dissection itself. This is the first time we're doing this kind of session in the pathology, which will be around 45 minutes. So please understand we've been a lot in the pathology, but this concept is new. We'll do our best. Victor, Reva, and I will lead it, and we will try to make it as good as possible, but we will welcome comments, and everybody should say what they think, so it will be good. And then we go up again. We will have breakfast here with the industry. I would be happy if they can tell us a bit about the products, and some minutes, everybody from our friends in the industry. And then maybe we manage to look at a case or two, and then we go down to the animal lab. Our animal lab is great, but it's not big. So we will try to manage there. There we will have 4 hybrid suite or hybrid rooms, 4 stations. I divided you guys, and I hope it's okay, but I'm sure you will be happy with it. Of course, we can change and modify. In 4 groups, all 4 groups will do the procedures together and train on the different aspects of the vascular access, on the REBOA, ABO, on other aspects. And after lunch, we'll be here. We will try to do more advanced cases like injury to the brachiocephalic or to the great vessels. We can do a lot of things, use onyx and coils embolization. It depends on time limits and how much you want to do. This is the main point. And we will finish at exactly 15:00. We will be here and finish with a short discussion. Questions or remarks? If there is any problem, you can speak with me or one of the colleagues. Okay. I will go fast to something to what is EVTM. Just fast, what are we talking about? EVTM, endovascular and hybrid trauma management. So how to use endovascular tools and other tools to stop bleeding. And the principles are quite easy to understand. Endovascular tools can help the bleeding patients. There are a lot of lessons learned from the aorta part, and there are things you can use today, and they are being used more and more. Early multidisciplinary approach, you will speak about this a bit, the Presto concept, but depends on the hospital, depends where you are. You can activate resources very early to use them. So the idea of calling your interventional radiologist 2 hours after it's been bleeding and you don't manage, it's not such a good idea in our view. How to do it and how to incorporate depends on where you are. Permissive hypotension, there is more evidence today, limited, that patients should be kept on permissive hypotension. Even in trauma, there is more information from the ruptured aneurysm. Early femoral access, we call it the AABCDE, and might be controversial, but the idea is to do vascular access on the primary survey. I am a strong believer in this. I don't know if I'm right or wrong, but I personally feel that every trauma patient, severe trauma, should get a vascular big access on arrival while you intubate. And I don't see a reason why it shouldn't be done. But this we should discuss. REBOA or ABO, or partial REBOA, partial ABO, which is a new concept, if needed. CT angio, and this is very important. Today, more and more patients are going through CT, and it's a question of when and how to do it. Depends also on the hospital. Always operate on a sliding table. Personally, I don't see a reason to operate trauma on a normal table. There are some limitations, it's a bit wider, but you have more tools in your box when you stand there. Hybrid in mind, can endo help me? This is the concept in general. It doesn't matter if you have a hybrid room or have this great C-arm. You can do things in a normal operation room as well as in a hybrid room if you have good equipment, of course. CT and access to perform what you want, for example, ABO or embolization. Everybody talk about Rebois the whole time. This is as the guys in the US call it, the new kid on the block. Am I right, Johnny? The new kid on the block. Todd Rasmussen, Joe DuBose, Thomas Calais, and all these, Megan Brenner, etc., etc. Everybody speak about Rebois, but I feel anyway, and I think my colleagues feel the same. It's not the Rebois. It's a vascular access. You have a vascular access. You can use the Rebois. You don't have access. It's not relevant. Access can be done blindly, fluoroscopy guided, ultrasound guided, cut down. We're talking about Seldinger method in over the wire method. And there are some extreme cases which is not easy and some others which are easier. It can be used for lab test, invasive blood pressure monitoring. You can give fluids, you can use the Rebois, the ABO. And of course, you can do embolization later on. You can use coils, you can use Onyx. Onyx is also new for this indication, but it's not related to the coagulation status, so it has a potential to be used. The access, my colleagues will speak about, but this is a CT that demonstrates the problem with the access from the femoral artery when you see when it goes down to the iliac and it disappears behind in the patient. And where to puncture, I'm sure that Thomas and Artai will mention, and we will speak when you do the different maneuvers. Rebois itself, as I said, the new kid on the block. A lot of information or a lot of enthusiasm came from some articles like Martinelli, 2010, 13 cases, and Brenner with only 6 cases. But then we forgot who owns this, and it's the Japanese. They did more than 405 cases, to my knowledge, done in Japan. But unfortunately, they do not communicate out with this. So now only lately comes this information from Japan, and it would be very nice to hear about it. So this is not new. This was done by Hughes, Colonel Hughes 54 in Korea War, and there are a lot of publications, not a lot, but there are some publications. There is no evidence, real good evidence. We have some of the people that have been involved in this, like Johnny there that wrote a lot about it. It would be nice to hear the discussions about also the evidence with this, if it's okay. I hope this will work. This is an animation how to do to use the balloon using Tokai rescue balloon. It's an animation also only, so consider it so. But it shows where you want to go in, how to identify the landmarks, to go into the femoral artery. By the way, the femoral vein is a big, very useful vein, and how to go in. Everybody here will share the knowledge, how to do, what not to do. But the idea is a Seldinger method where you puncture it, and then you get a guide wire inside. In general, in most of the product, there is one new product that don't use guide wire. We'll speak about it later. And then you go up, and then you can put your Rebois or ABO either in zone 1, up in the thorax, zone 2, which is pararenal, or zone 3 before the bifurcation. We will discuss it later on. You have to keep your wire in place. You take out the needle, and the wire is of high importance, not to lose your location. You use an introducer. An introducer is your way into the vascular tree. And this is very important too. And when you have the introducer in place, and when you flush it, then the way is clear. In general, you can say that this is the way, when you have the introducer inside, the rest is a minor problem to change it and put the Rebois, but my colleagues will speak about it. This is the rescue balloon when it's coming up. The rescue balloon comes over a wire that is 0.038, a small wire, 2.5. And then you take out the wire and you put a hard shaft inside that will come soon to stabilize the rescue balloon. The company, Tokai, is here, Ishihiro from the company, and he can give tips about it, and of course our Japanese colleagues. You can use it for total occlusion, you can use it for partial occlusion, and I think this is the upcoming thing with partial occlusion. You can use it also intermittent, heavy there, and use it if needed, when needed. And of course, take it down to the bifurcation. Let me continue and then take it out. The Örebro vascular kit this is our ER. This is how it looked some days ago with the trauma case. This is how it looks in our place with everything you need for the vascular access. This is how it looks in the surgery app that you can take it with you. This is the Boston Scientific balloon that we use, and wagon with all the things that you need for an emergency situation. These are the zones I spoke about, how it looks in Rebo in different zones. I will take it later on. And this is, oh, I'm sorry, it's a bit, it's lying down, I'm sorry. But this is a prior ER Reboa balloon used in shock and trauma on a cadaver, how you measure the balloon outside the body. I'm sorry that it came this way. Shock and trauma, trying to use more the Reboa, and now this balloon was never used on a human being. Joe DuBois can tell us more about it. This is a case with a partial occlusion that we just also published, and one lesson, important lesson that we learned, that you have to hold the balloon, and we don't like fixing it. You have to hold it. It's a living entity, the Reboa, and then you can use it in different ways. We will talk about it later. Some other issues we are dealing with, we're now underwriting of some manual that we call Top Stent. It's around 6 or 7 chapters are in advanced stages, and the idea there is to share knowledge from different people in a venture that is done together to try to give all this information in a nice way. We will do a meeting here in Örebro 2017, which we call EVTM roundtables, when we will try to discuss all these issues. And we're gathering people from the whole world to participate. And the preliminary program looks like this, and it will be on vascular access in trauma and bleeding, aortic balloon in trauma and bleeding, how to do it organ for organ, pre-hospital and military issues. This pre-hospital has done several times in London. Some of the guys are coming here. Sammy and Garrett will come here soon. They're a bit late today. And we will speak about training issues. For example, who should do reborn, which is a huge issue. And of course, about animal research and the very important ICU aspect, how to continue treating these patients. Thank you so much. And please just ask questions, feel free here, it's very important. Until he puts it up, I want to present one person more there. It's Johan Wallin. Johan Wallin is the head of surgery here, and he supports us very much. And one person that I don't see right now, he will come later, is Matthias Sandin, the head of cardiothoracic and vascular surgery. I guess he will come later on. And I thought about after Thomas' presentation, where we do a small pause and present ourselves, if it's okay with you.
It's like a sign that your enters the scene right now. Guys, I tell you why. Because I'm going to talk about lessons from rupture. It's a bleeding patient, and in many ways similar as the trauma patient. I will focus on the access. I will share with you a moment in Swedish history, and this is the Swedish September 11, 2 years after World Trade Center, and this is the Swedish foreign minister who was stopped outside in central Stockholm, and she eventually died. She was transported to the absolutely best vascular trauma center in Sweden, to the Karolinska Hospital, and Göran can tell more about this. She was actually, can you take this away? She was actually had surgery and blood transfusions for over 9 hours, and she had reported severe internal bleeding and liver damage, and the outcome was negative, and she died at 5:29 in the morning. This was actually done. She was actually, she suffered from the trauma triangle of death with hypothermia, with acidosis and coagulopathy. This was the golden concept created in the 80s. This was also a moment in my head, because when this happened, I thought, can it be done in another way? And actually, Richard, you was on the clinic that time. We started an informal group, and we had a concept which we called the Anna Lindh operation. And the new with the Anna Lindh operation was that we should implement use of endovascular techniques to control bleeding in an early phase. That was the first thing in my head about this new trauma concept. Because 3 years earlier, we had shown in a ruptured aneurysm that it was possible, even if the patients were more or less dead, to treat the patients under local anesthesia with percutaneous access of the femoral artery, having a balloon inserted and inflated in the arch, and then she recovered, and simultaneously a thoracic stent graft was implemented, was deployed, and this patient had a successful outcome, and she lived for many, many years after this procedure. So we had actually 4 years before started to do endovascular aortic repair, and in 2001 we understood that this was the way to go even for AAA, and we introduced the percutaneous technique, the percutaneous access, and the first ruptured aneurysm was reported in 2001. We had to copy with the best surgeons in the world who says they can get control with open repair in 5 minutes. I don't think it's 5 minutes. But that was our benchmark. And the only way to do it in 5 minutes was to have learn how to do a safe and quick percutaneous access. So what's the anatomy we need to know? We have some reference points. This is the bone, the pubic tuberculum. This is the ligament, which you can palpate. And if you have 2 fingers here, you will be normally in the right position for the vein and the artery. The other thing is that you have the branch, the deep femoral artery takes off, and above the inguinal ligament, the artery goes into the deep. So you want to be in the distance between these 2 reference points. Normally, it corresponds to the mid-caput femoral. And this is not it's normally 3 centimeters, not more. If you have fluoroscopy and you don't know anything, just go for the mid-caput femoral and puncture. If you do it blind, normally the point where you feel the best, the femoral pulse best, is the point to make the access. But sometimes in a shock patient, in a beast patient, it can be very harsh. And then you have to rely on other points. Also, think about the angulation. Think about the subcutaneous tissue that can be thin or thick. Normally, from the skin to the artery is 2 to 3 centimeters. But it can be less than 1 centimeter and above 4 centimeters. If you have a very angulated puncture technique, it's very hard to say from the skin where you actually will land. It will, if you have a fat patient, you will have a high puncture. And the high puncture is not good because it's harder to control and more easy to get bleedings. I show you now a film about basic access technique. Ska jag ta ner den här åt dig? Okay. This is a patient that is not fat. It's a rather slim patient, and I try to palpate where the inguinal ligament is, and then when I know where the inguinal ligament is, and about 2 fingers from the tuberculum pubicum, if you don't feel the pulse, if you feel the pulse, I puncture between my fingers. Now I demonstrate the angulation of the needle. That if you see it here on the skin, and if you have a very high angulation, you will come up much higher than you have expected. So I think that my technique is about the 30% angulation. This is local anesthesia. It's a small needle, and you can actually, during infiltration of local anesthesia, also aspirate, and then you can see when you're in the vessel. So now you are in the vessel, and now you know where the artery is before you take the bigger needle, the needle that have a channel for the guide wire. It's good to make a skin penetration, and don't stress in this situation. Don't stress in this situation, because if you stress, you can end up with problems that makes you in the end to take longer time. I go slowly down, and normally, if it's not a calcified vessel, I can feel the palpation to the needle. So I don't puncture the back wall, I just puncture the front wall. And if I have a resistance, I don't go through, because it's very easy that this needle has catch it up against the plaque, and if you move forward, you will end up with a dissection. So don't be stressed in this situation. And this is really more or less a live demonstration of what actually happened. It's not made a lot of, things in the computer. I change the direction, do small movements with a needle, and are very gentle with my fingers. If I have a resistance, I'm not pushing. Now it looks like I have access, and it goes easy. I think we can break there. Thank you. This is how it looks after a dissection, and you see that there is it's different. It's more density here of the contrast than here. So the contrast is accumulated in the pouch of the dissection, and later when the contrast is washed out from the true lumen, it hangs in the dissection pocket. This doesn't do any harm, just leave it, because the flow will come from here, and the dissection will heal by itself. So don't be stressed by that. Now, if you have an access, how do you close it? And we talk about two different accesses. Small bore, which is up to 8 French. And 8 French divided with 3 is actually the size in millimeters. So it's almost 3 millimeters for small bores. Compression is a very good alternative, manual compression. Also, there are a lot of closer devices on the market. And I will not mention everything, but basically for this small, either it's external compression systems, for example, the thermostat, or it's different devices with plug, based on plug technology. You must know that these devices have a learning curve. So if you are familiar with them, you can always do compression. When you come up to large bore, from 8 French up to 25 French, we are talking about 8 to 9 millimeters now. Compression is not an alternative. If you don't know anything about nothing, you know about surgical cut down, so you can always do a surgical cut down. There are a couple of devices in the market based on sutures, and also the technique we have implemented here in Örebro since 2001, and we use it also in all elective situations, and that is the fascia suture. I will go through briefly these two techniques. The ProStar to the left and the ProGlide, all are based on needles that from inside of the vessel lumen, needles goes through the vessel wall, and this is done before you expand the hole. You cannot insert this device if you have a hole larger than 8 millimeters. The technique is the same for the ProGlide system, and this is called pre-suturing. You need to do pre-suturing, and then that I will say is a big disadvantage when it comes to acute situation. So we are very, very enthusiastic about this technique that we started in 2001. We have evaluated 2006 and last year also in a randomized trial, and we know that the results are excellent. You don't need any pre-suturing. You don't need even to touch the artery wall. You just use the surrounding fascia that is a few millimeters above the artery, and like the purse string suture, you take the fascia together. And with this technique, you get an excellent sealing, comparable to the ProGlide when it works. The ProGlide, for example, has very bad results when it comes to very calcified vessels because the needles cannot go through. It's independent of how the artery is, this technique. I show you a picture of a film of how this is done. Vi kan visa den där AVM-filen du. Vi kommer till den då. So 4-5 centimeter incision of the skin, and now just plumb technique. The fingers is excellent, together with retractors going to the soft fatty tissue through the subcutaneous fascia and down to a more dense resistance, and that is the fascia that is above the artery. And then we have a suture that We have two deep stitches on each side of the artery, as you see here. We use the Gore-Tex suture, which has very good gliding capacity, and we create a fisherman's knot. So when we pull in one of the sutures, then it goes together, and we pull, take out the introducer with its tapered dilator, and just pull, and that's all. We take out the wire, and this is a very fast technique, and it's also reliable.
Can I ask you something?
Absolutely.
Isn't there a risk that you actually take such a big bite that you suture the artery itself?
Yeah, that's why we did the randomized trial and compared it with the ProStar device, and that was not the case. The results, the primary results were equal. There were the complication rate was not different. However, what we do is, now that we always, it can happen, and what we do is that we have a Doppler and listen to the vessel before we close the skin. So we take that into account. Yes.
In how many cases did you do that? In how many cases did you do this?
We have started 2001, and we do it almost in every case. The only case where we do a primary cut down is if we had a heavy bleeding, some problems during introducer shifts and so on, because then the fascia is elevated from the artery. That's the only case where we actually do a primary.
You had no case that you sutured the artery, or what were the complications of
Yeah,
this procedure?
the most common complication in the randomized trial was bleeding. Thrombosis happened, but that was a very, very small portion of all of them.
Sorry, can I ask? Typically, what sort of learning curve did you, for people to become proficient, how many cases would you say?
For this trial, we had 15 procedures as the cutoff. Probably it's manual and so on. Probably you need more. You need much more to handle the mechanical suture devices. But there is a learning curve also for this. Now you think I'm ready? No. Don't forget the venous bleedings. I show you a case, and take that in your mind and think about what can be done with this concept. This man had an exclusive trauma during acetylene welding, 55 years old. At the emergency department, he had a circulatory arrest, cardiopulmonary resuscitation, transported to the open theater, and open exploration, which showed a profuse bleeding from the iliac vein. What did we do? Well, we accessed the common femoral vein and inserted a stent graft from the bifurcation and well below the region of trauma. And then we did damage control. I don't know if you were on this case, Rika, but you remember, I'm sure you remember it. We had stapling, multiple staplings in the gut, and had a Bogota bag. And this is the post-op CT. And now you see, you think you have bad equipment. You think you have bad equipment. You have excellent equipment. That was done 10 years ago, and that was how CT looked like. So this is the CT, and this is the stent graft. And this, the secondary survive. Actually, a fragment, a metallic fragment, had penetrated the common femoral artery, and they had a thrombosis, so we could handle it with thrombectomy. We had to do some resection of gut and necrotic muscles. And the plastic surgeons did a marvelous work with lumbo technique. And 8 months after, he was back in work. A hybrid concept to solve a life-threatening condition based on venous bleeding. So, in summary, the EVTM concept means liberal indication for femoral access. Tali says always do I would say almost ever do femoral access. Don't be afraid to do it. You can have just a small access. That offers immediate access for an aortic occlusion balloon. You can use it for monitoring. Maybe you have faster access instead of doing the puncture of the radial artery. You can also have fluids in if you really need it. And there are many devices for closer or small bore accesses. But when it comes to the large bore accesses, we think that the fascial suture is the most well-fitted method today for closure of large bore accesses. Thank you.
Thank you. Let's move
Thank you for
Okay.
this very impressive presentation. I have a question for you and for Ted also. You mentioned before that to have very early or to be very liberal in having a femoral access. We are very liberal in having a venous femoral access, but this is a huge change in our practice to have also an arterial femoral access in trauma.
I think first, when you find the vein, then great, stay in the vein and use it. It's I personally think that this area is underused for vein and artery. I want to hear, guys, what do you think in the artery? What do you guys think and other people? Let's open it for a short discussion.
In many trauma cases, you need a lot of hands. And the trauma cases I've been involved in when we have had hybrid approach to the patient, as a vascular surgeon with endovascular knowledge, I'm in a perfect place between the legs of the patient.
Yeah,
So I'm standing there, far away from the laparotomy team, and I can add some knowledge or fluids or balloon closure, the ABO, and it's a very good. The geographical place is very good because you're not away in the way of the C-arm or for the laparotomists.
Yeah,
So the hybrid concept is good, and the femoral axis is very nice because you need hands there.
Yeah, but this is a very safe area and whatever. I don't know if it's very safe when you have a very bad pelvic trauma, but it's very safe for femoral venous access. To start with the venous, and after that, where the femoral artery access in every trauma, like severely trauma patients, and this is a huge change in my practice. Femoral venous access, yes, we are doing that every time. But
What they say.
arterial.
Yeah, but I'm in purpose saying in radical that major trauma should get access. I think it should be open for discussion. Martin, do you have any?
Yeah, as long as there is a need for it, because I think it could delay other more urgent measures. So I think you should have some dedicated personnel doing that while other people doing other things. So this is not the focus, so to say. And a few words about Thomas' excellent speech. We often use the micropuncture needle. You're familiar with the micropuncture technique? It's 0.9.
Monica, if we can get some micropuncture.
It's 0.9, a very, very thin needle that you can put in a 0018 guide wire. You can use this small needle to give your local anesthesia around the vessel. And once you get arterial drawback from when you aspirate, you can put in the the tiny 0.18 guide wire, and then you have access in the same situation that you do your local anesthesia, which saves time, and also you can try at different places more than if you use a larger needle.
It would be great if you can show what you mean later on the dots.
Yeah, sure.
We will fix it. Monica will fix it. Okay, can we go on? Before we go on with RTSP, can we just go through the participants? We can start just with the names of everybody that sits here. Just name, what do you do, where do you come from? Ralph, you start just fast.
Okay, Ralph Tam from Stille, manufacturer of operation tables.
Clarissa Mogojan from Stille, manufacturer of tables.
Per Bonefeld, residence in emergency medicine here in Örebro.
Hello everyone, I'm Tim. I'm a consultant in orthopedic trauma in Helsinki.
Hello, I'm Tuomo Pyhältä, Helsinki, Finland. Also orthopedic trauma surgeon. Hello, I'm Jussi from Helsinki, same center as the guys, and I'm an international radiologist.
Hello everybody, I'm Ahmed Qasim. I'm an assistant lecturer of vascular and endovascular surgery, Alexandria, Egypt.
My name is Hani. I'm from Haifa, Israel. I'm the chief of trauma and emergency surgery in the hospital.
My name is Mirgani. I'm a vascular surgeon from Scotland.
Hello, my name is Kjell Ögren. I'm an anesthesiologist at this hospital. I'm sort of in between instructor and participant. So I'm just a spare part in this course, but I saw some of you last spring, actually.
Hi, I'm Rickard Lindgren. I'm a surgeon here in Örebro.
Hi, my name is Habib Talib. I'm from Jordan. I'm a nurse, trauma nurse. I continue my master's degree in critical care, and my PhD is in trauma nurse management.
Hi, I'm Yuri Kon. I'm from Japan. I'm an emergency physician and radiologist and interventional radiologist.
Hi, I'm Tomo from Japan. I am an ex-trauma surgeon and I'm now I'm an emergency ER physician and interventional radiologist and intensivist. Nice to meet you.
Hi, my name is Jun from Japan.
Ishihiro?
Yes, hello, and this is I'm Makimoto. I'm from Japan, and we are from Tokai Medical and manufacturer of rescue ground.
Okay. Mikael, can you continue?
Hello, I'm not a vascular surgeon. I'm an upper GI surgeon dealing a lot with trauma, even in the military setting. I'm working in Umeå.
In the north of Sweden.
In the very north.
Very north. A bit more snow.
Hi, my name is Linda Vilos. I'm a general surgeon and a resident vascular surgeon at this hospital with these guys.
Hi, I'm Gareth Williams. I'm a vascular registrar at Southampton General Hospital, UK.
Can you continue there?
Yeah, I'm Pekka Aho, a vascular surgeon from Helsinki, Finland.
Hello, I'm Maria Sörastrom, vascular surgeon from Helsinki, Finland.
I'm Victor. I'm a trauma surgeon, trauma vascular surgeon from Military Medical Academy in St. Petersburg, Russia.
John Morrison, my final stages of my general vascular training in the west of Scotland.
My name is Jonas Stromberg. I'm a general surgeon from Kalmar. I'm a trauma responsible surgeon at Kalmar County Hospital. And I just recently came back on this Sunday from South Africa, 6 months trauma training. Hello.
Hello everyone, Mordan Anay from Jordan. I'm general surgeon. Hello everyone, I'm Johan, cath lab nurse at this hospital, along with Christian. My name is Jonas and I'm the medicine. Thank you.
Hello, I'm Daniel. I'm from The Hague, the Netherlands, a vascular surgeon.
Hello, I'm Eric Honkert. I'm one of the chief residents. I'm finished in several months in The Hague as a vascular surgeon and a trauma surgeon. And I was also in the armed forces for several trainings.
And just did your PhD on these military aspects.
Correct.
Hello, my name is Petra. I work here as a theater nurse with you guys.
Hello, Niklas, nurse anesthetist. I don't know.
Hi, my name is Anton. I'm a medical student here at the university in Örebro.
Going soon, I hope, to South Africa to do some projects regarding the geo. Can you continue here, guys, just to show yourself?
Hello, I'm Mats Torstensson, representing Toshiba Medical, Sweden.
I'm Peter Eckerström. I'm from Bingmet, the distributor of Mentis in Sweden.
Hello, I'm Sofia Martinsson, and I'm here with Mats, representing Toshiba Medical Systems Sweden. It's really here.
Hi everyone, Edward Felt from Mentis with endovascular simulators here as well. So welcome to try it out later on.
Thank you.
I'm Carl Platzer from a communications agency called Association in Stockholm. I'm here to document this for a global audience. My name is Uwe. I'm a military surgeon from Hamburg in Germany.
Welcome.
I'm Gilad, I'm from 3D. We make the 3D printing. The dolls you're going to train on. I hope they will be fine.
My name is Anders Berg, coming from WL4, working with peripheral stent graft and stents.
Yeah, Stefan from LDN. We are here with our C arms from C.
I'm Vesa from Team Units in Finland, and we are making these beautiful Sudans.
Hello, I'm David Archer. I'm also from LDN.
I'm another pig nurse.
I'm Christoph Nilsson. I'm resident in anesthesiology intensive care here in Örebro.
Hello, my name is Mitra Sadegi. I'm a sterile surgeon here in
So hello, my name is Markus Steinhardt. I'm the European Training and Education Manager of Medtronic.
Michael Farrelly, Marketing Manager of Peripheral Embolization, Onyx concern in the vascular plaque. You're going to see tomorrow.
Hi everybody, here we are. My name. I'm also together with these guys over here at Medtronic in Training Education.
Danny?
Hi, I'm Daniel, owner of Meliora Medtech, distribution company in the Nordics. Distribution of, for instance, Tokai microcatheters. Hello.
Can you say hello to everything? Everybody, I think so. Just in the normal Swedish way, the emergency exits are there. When I come to Sweden, the toilets, there are 2 here and 1 behind. And please feel free here to change your position, do what you want, ask questions. All right, actually,
Hi everyone, my name is Dr. Pizon, I'm vascular surgeon here in Örebro. We had this course last time, and one of the feedbacks we got from the people was that we had probably assumed that everyone knows about this very basic and vascular technique. So they wanted us just to go ahead and say what the materials are in the vascular surgery. So this is very basic. Most of you probably know this, but please bear with me and I'm going to take you through this. Everything is based on this guy. Our way of thinking, the EVTM concept and everything is from this guy, Dr. Seldinger, who was from Uppsala. He came up with the idea and published how to get access into a vessel. So what you actually need, there are 3 things to get access into a vessel. You need a puncture needle, you need a guide wire, and you need a catheter. And that's all what you need. So this is the Seldinger technique. The technique is about to put a needle, get access inside the vessel with a needle, and you can insert a guide wire into the needle, and you can then take back your needle, and you have the guide wire in place. In this way, you can have access inside the vessels. Then over this guide wire, you can insert different things, your catheter, your introducers, and different stuff. So there are different kinds of puncture needle. Martin was talking about the micropuncture needle. These needles have a hole in the end, and most of them are you can put the hole to the top just to make sure that you don't get dissection when you come into the needle. To the vessel. There are different types, depending on what kind of guide wire you are going to use, what is available, and you have to have needle which is chosen for that. So you hear about 035, 025, 018, and that's the size of the guide wires. And in order to get these guide wires inside the vessel, then you have to have the appropriate needle. So that's if you have a thin micropuncture needle and you have a 035 guide wire, you can have it inside the vessel. So you have to think about what kind of what is the next step in order to be able to get access to the vessel. The guide wires are many. There are many types of guide wire, but most of them are curved at the top, and it's just because as soon as you come inside the artery that you don't get a dissection, so that this curve allows you to just navigate up the vessel. Guide wires have different dimensions. As I told you, 018, 025, 035. There are different properties of the guide wires. They are hydrophilic, they are non-hydrophilic, and they have different kind of properties on the surface of the guide wire. And they can be very stiff or less stiff. So you need to know what kind of guide wire you want to use. Of course, you can have a straight guide wire, you can have an angle guide wire. So if you want to start with the EVTM, then you have to have just a setup how to get access to the artery. We're going to talk a lot about this kind of access later on the dose. So please feel free if you have any kind of thoughts, share it with us. And if you have any questions, then you can go through them and try to see how easy these questions. As soon as you've come inside the artery, then you can get an introducer in. The introducer is your way into the artery, because the introducer has a valve at the top, which means that you can leave it inside the artery without bleeding out. And once you've got the introducer inside, then you have the possibility to change it to other introducers to come inside with the different guide wires. So this is your way into the artery. So there are, of course, different kinds of introducers. There are less big and there are big. Thomas was talking about large bore introducers. Those are more than 8 French, and the other ones that are less than 8 French. So everyone is talking about French, and we didn't explain what French was last time, I think. So what is French? French is a scale. It's even called gauge, and each 3 French is about 1 millimeter. So if you 3 French is 1 millimeter, and 9 French is 3 millimeter. So if you want to get access to the artery with a 4 French introducer, which is the micropuncture introducer, you create the hole in the artery, which is 1.35 millimeter. But if you want to, the current balloons that we are using here, they use an 11 French introducer, and you see that the hole in the artery gets bigger than about 3.5 millimeters. And our Japanese friends are going to show you the balloon, which is low profile, which is taken inside the 7 French introducer. So you should be familiar with the French scale, because it's going to tell you about, you have to divide it by 3 and see about what kind of hole you've got into the artery, because once you're done, you save the patient's life and everything is fine, then you have to take care of the access, and you have to have a way to close it. And then you've got the catheters. The catheters are hollow, which means that they can carry a guide wire, and together with the guide wire and the tip of the catheter, you can navigate inside the vessels. And this should be the case if you want to come from the femoral artery to the aorta. Sometimes there are calcification in your way. Sometimes the the guide wire doesn't want to go up, and they need some support from the catheter. So catheters let you have the support, they let you have the probability to move the tip of the guide wire. So it's a very nice way to navigate inside the vessels. Of course, there are tons of different catheters. They have different surface, which means that they can. Some of them are hydrophilic, some of them are non-hydrophilic. There are different profiles, and depending on where you want to navigate your guide wire to, then you can have different kinds of catheters. But yet again, if you come back to the EVTM, you don't need to have a lot of catheters. You need one guide wire, you need one catheter, you need one puncture needle to begin with. And if you want to go ahead and try to embolize bleeding, then you'll have more endovascular knowledge in order to be able to get to your organ. So there are companies who all have all-in-one. You've got the puncture needle, you've got the guide wire, which is round, and you have a small introducer. So this could be your kit for the ER if you want to get access to the artery or the vein. So you don't need a lot of things just in order to come to the vessel. So everything, we think that it is not about the balloon, it is not about any fancy things, everything is about the access. Have the right tool and have the right knowledge to just come to the artery. Very basic.
If there are some questions, I will just write to John Dubos that we have a bit delay. So if there are any questions you want to discuss on 1 minute, I will just write to him. Questions, remarks?
The use ethics, for example, 4 or 5 French sheet makes a whole of not 3 French, 1 maybe. This is the inner diameter of the sheet, not outer. So the hole will be a little bit bigger.
But normally we say that the 5 French introducer has an outer diameter of maybe 6 French, a bit more. So you put 1 or 1.5 depending on the thickness of the introducer. Right.
Okay. Well, maybe we should continue. I think it's Martin's.
My turn.
It's okay. And then until he prepared, and then we'll get coffee here and everything. And if you have any comments or questions, of course, to the people here, just ask. I can just say one point. It's always at least when I'm in the trauma situation, I'm asking the one responsible, should I do access or not? Just tell me what you want. I'm a strong believer in this, but of course, Hani has a big point there. Should everybody get it? But in general, I want to take the radical issues in, and we will see how it formulates.
What is the trauma here, like in your hospital?
Here's the general surgeon. It could be, for example, Rickard. He's standing there. He's responsible. I'm the vascular. He calls me. They activate us very early because they know about these things. And what can we help? The question, who should do an access? It's a complex question in which hospital in the US the trauma surgeon want to do it, in Japan maybe the radiologist. We will discuss it, but it's how to deal with trauma and who is responsible.
First of all, I want to thank the organizing committee and, of course, Tal for the opportunity to be here. It's always a great pleasure to come here to Örebro and meet you guys. Also a great pleasure to see all of you with this heterogeneous amount of people with different specialties. That's really great. So I can't avoid to color my presentation with a lot of X-ray color, of course. So I'm kind of a geek, and if you think Artai had materials, I will give you a lot of more material to look on. So you have to excuse me. This is my chance. Take it. But still, as a radiologist, of course, you are only a small part of this heterogeneous complex pattern which have to work together. And I think that's the great challenge in this business, is to get all these pieces to work together. I hope we can discuss details about that also. So what can we contribute to as radiologists? Of course, you think of balloons, guide wires, and stent grafts and so on. But one very, very important issue is also the imaging aspect. If you know what you have, the problems you have in front of you, then the chances for a successful outcome is far better than if you stand in front of a patient and you don't know what to do. Where is the bleeding? What is the extent of the trauma, and so on. So knowledge is everything. That's why I am of the opinion that if it's a possibility to have a CT angio of a patient, you should do it. And a standard procedure with the CT is to have a native phase, arterial phase. That means that you take your images about 20 seconds after the injection, and a venous phase about 70 seconds after the injection. That's a kind of a standard in most hospitals. And the modern technology makes reformatations possible, so you can have a very detailed image of what's going on. This is a patient we had a couple of years ago who suddenly become hypovolemic after a liver puncture. The question was, of course, is this some vessel in the abdominal wall? Is it from the liver? Is it any other vessel that is damaged? And you can see very clearly that there is an extravasation here below the liver. And you can also do these MPR reformatations and could identify that the bleeding came from the 11th intercostal artery. And then it's a piece of cake to go in and up in the descending aortic part and find your way with a reversed selective catheter and go selectively and find the bleeding. If this information would not be at hand, you would have to do a liver angio, aortography, and so on, and you lose contrast, you lose time. So this is just an example how valuable it is. Just two images of the coils that were put in the distal part of the intercostal artery. The coils give hemostasis here, and you can see there's no more extravasation. Hybrid room, of course, cannot be overestimated. To work with a C-arm at the OR can sometimes be the only option because it's necessary. But too many times you stand with this patient with a lot of blood, with high radiation doses, hard to see what's on the monitor and so on, which can adventure the whole procedure. So if you have the possibility, use the hybrid room and try to make it work also during weekends and nights. So let's go into the more detailed procedures. You have, of course, to save the situation. If you have a severe hypovolemia, the patient is dying, you can't think of embolization or coils. You have to make the situation bearable so that we have a blood pressure enough to serve the brain and the heart, to create temporary control with Riboa, and then stop hemorrhage, and eventually repair vessel wall damage if larger arteries are damaged. Tal talked quite a lot about this technique, and we'll talk more about it later. But basically, this balloon is compliant. That means that it's elastic. The reason for this is that it's a powerful tool, and if you inflate it too hard, it can break the aortic wall. It has happened, and I'm sure it will happen in the future. So you have to be very careful with this. You can treat aortas in the range of 10 to 46 millimeters with this. The Reliant balloon goes through a 12 French, and this Coda balloon from Cook. Reliant is from Medtronic. goes through a level French. And also you have to have a super stiff guide wire because the pressure of the cardiac output forces the balloon to go downwards. You can't manage it with a soft guide wire and no support from an introducer. You have to have both to keep the balloon in place once it's about to reach the aortic wall, because even though the patient has a low pressure, it's quite a significant amount of power working at the balloon. So this is just a few tips and tricks. If you do this blindly, if you have a fluoro, you can look at the balloon and see when the balloon with the contrast and saline finds its shape towards the aortic wall, it will become oval or almost square. However, if you do this blindly at the ER, this is much more difficult. Then you have to guess what the patient's aortic diameter is. In young, healthy people, it's about 15 millimeters in the abdomen, 20 millimeters in the thoracic area, 2 millimeters more in men compared to women. And then in each package, you have a table that correlates the volume you inflate with the volume you inflate with the balloon diameter. So, for example, here, if you want a diameter of 20 millimeters, you should inject 9 milliliters into the balloon, and that's a good help. In combination with your fingers, you can feel that there is a small resistance when it begins to reach the aortic wall. This is only temporary control, of course. You will have a metabolic burden after some 15-30 minutes. So your ambition should be to have an as distal occlusion as possible. This is an example of this, where two balloons are inserted into the internal iliac arteries in a postpartum bleeding, and inflation of this 9 millimeters balloon with the crossover access is the same as doing a clamping surgically. You have to choose the right balloon size. We used to use 8 millimeters balloon, but checked a couple of times with a contrast injection, and you can see that if the patient is large and pregnant, the internal iliac arteries are larger than normal during pregnancy, and the balloon will not give contact to the arterial wall, and you will have contrast through the space in between the balloon and the arterial wall. So use a little too large balloon instead of a too small. The different type of catheters might seem like a jungle to you that are not familiar daily with this intervention stuff. But I can say that when you get to get access to the area you should treat with embolization or whatever, you only need some 3 catheters with some variations in the shape. And that's a reversed catheter, which is very good for catheterization of the abdominal vessels. A headhunter, which is very good to get access to the branch vessel from the arcus arch. And a cobra, which is very good to reach access when you go crossover or into the intercostal arteries. So just find a few 2-3 catheters, and you will find that they can solve your problem in more than 95% of the cases. In combination with these 0.35-inch catheters, you, in a vast majority of cases, have to use a microcatheter. That is a catheter that has a small lumen and fits inside the lumen of these larger 0.35 catheters. So it's a kind of coaxial system. Once you get the catheter in place, you can put in different things. It's like the Swedish smorgasbord. You choose what you think is most appropriate in the situation you are in. And I tried to place them in this picture from most proximal to most distal. That means that if you want a proximal occlusion, for example, in the internal iliac artery, you use a plug that will give hemostasis in 5-10 minutes. Then a little bit longer and longer out, you can use coils. You can use onyx that by your injection finds its way more distally in the vascular tree. You can have gel foam, which are cut into small particles, and they will stop at branches which are about 1 to 2 millimeters, and then you go for about 1 millimeter large particle which go out to the arterioles. You should not use smaller particles than this, because if they come too distal, they will give a severe ischemia, and you risk ischemic damage to, for example, the buttock or the intestine. There is a vast fabrics of coils which have dichrome to increase the coagulability. They can be covered with gel, which swells up and fills up the vessel in contact with blood. But in common, they are made of ethanol and platinum, which makes them fall into their original size if the vessel is big enough to create turbulence in the flow. If you have a critical area with unstable catheter position, it's very good to have a detachable coil. That means you can place the coil, you're satisfied with the position, and then you release the coil. Otherwise, you can only, if you don't have a detachable coils, you can only push it forward. And if you notice that the catheter withdraws from the position, you can do nothing. You might end up with a coil in wrong artery. So I recommend to have detachable coils on shelf. Another example, this is a case we had previously this fall. It was a young man who was stabbed at the supraclavicular fossa, had hypovolemic shock, and CT showed extravasation in the collapsed area of the lung here. It was air in the mediastinal space, large hematoma, and pneumothorax and hemothorax. And it was hard to see from the images where the blood came from. But doing the angio, you could see that that there was extravasation from a branch from this from the subclavian artery out in the thoracic in the pleural volume here. And once you have the position of this H1 headhunter catheter, you can go out with the ProGrade microcatheter and place some microcoils there. It's just some 5-10 minutes and the job is done. Another technique, if you have extravasation from a branch vessel of a larger feeding vessel and you can't get access into the vessel here and place coils, you can use the sandwich technique. That means that you place coils here, and thereby you stop the blood flow to the damaged area. Of course, this artery cannot be a major artery, for example, to the arm or to the leg, then you will end up with ischemia. But in smaller arteries, it's a perfect technique. Just another example of how quickly coils work. This is a large pseudoaneurysm after elbow fracture, which was operated by the orthopedics. And you can see that the ulnar artery is cut and there is a jet out in this large pseudoaneurysm which is filled with contrast. And by microcatheter technique, you can reach all the way out to the target area. You put in some microcoils and you will have a stopped flow here. And in a couple of weeks and months, this will be reduced and later on disappear.
Martin?
Yes?
Can I comment or have a question?
Yeah.
Can you go back one slide? In trauma or iatrogenic or from outside, you can have a cut artery or like here an injury to the artery. And then it can be easy, it can be accessible to get the proximal part of the artery, the main bleeding spot. But your experience is that do you have a lot of problem with back bleeding from the part of the artery that you don't reach?
Yeah, that could be a problem, but I think a bigger problem is when collaterals go from, if you occlude the main artery to the bleeding area, a wound for example, then the perfusion pressure in the area will go down, and that makes that collaterals are instead feeding the environment with blood, and the bleeding will still go on. So in these larger arteries, I think back bleeding is not a big problem, especially in the late phase of the angio. You can see that there was no feeding of blood up to the area. But collaterals as well as back bleeding is a problem. Then sandwich technique is better.
Have you used some liquids or onyx in any bleeding?
Not in
ACBA,
trauma,
MSK,
but it's an excellent method in trauma. We use onyx more and more, I would say, in the vast majority of cases when it comes to endoleaks in aortic aneurysm. It's really a good technique, and we like it very much. And I think it has a good place also in trauma care. The only thing is that it's a little bit time consuming. You have to do the onyx injection slowly, 0.3 milliliters per second, and it takes some 10-20 minutes to fill the area with onyx. So you can't have too less time to do it.
If you have a larger artery injury, like the subclavian artery, in between thorax and outside thorax, and you get a good position with your catheter in the proximal part, you can embolize with or put an plug. Do you take time to get another access on the other side of the injury, like the distal access from the radial artery or rectal artery?
Rarely.
Your
Because
experience is that it's not a problem.
I do it if I need to, because I think you have to prioritize time and tempo in your procedures. So in majority of cases, you can solve the problem from the groin access. If not, then you have, of course, to go from the arm.
But that's not a big problem in your experience.
No, of course not.
That's a good point, I think.
Okay, some few words about particles and gel foam. I think they are most commonly used in severe pelvic trauma. With complex pelvic fractures, you often have diffuse bleedings, which are hard to manage. And and this was a case with a suicidal person who jumped from the fourth floor and had a severe hypovolemia. And you can see here is metal from external fixation of the hip. There are damages to the common femorals, and in a later angioseries, you can see that there are diffuse spots of bleedings in small arteries adjacent to the fracture areas. And here you should not hesitate to go in with the catheter into the internal iliac artery. Don't be selective. Go down a few centimeters and go in with gel foam, spongostan, or 1 millimeter particles, and you inject them until you get a slow flow. If the contrast with the particle disappears within 5 heartbeats, that's about enough.
So
then you have a good.
So you are embolizing the bilateral femoral arteries?
Yes. No, the internal iliac arteries. Yes. And here it's important not to use too small particles. I would advocate to use gel foam here because you get particles between 1 and 2 millimeters. And in 1 or 2 weeks, they will disappear and they will revascularize the area of the pelvis. I'm not sure if you have seen the technique for doing this, but the spongostan gel foam comes in place like this.
Are you a chef's cook or what are you?
I always try to impress on you, you know. You cut it into small particles and you put it in a 10 or 20 milliliter syringe. They are quite light, so they are hard to handle. And then you take 50% contrast, 50% saline, and then you use a 3-way stopcock to mix them for a couple of minutes, and you get some slush or jelly, which you then can inject through your catheter. If you do this, I think you'd better use O35 catheter, because if you use the micro catheter, it will be blocked by these particles. But if you use polyvinyl alcohol small spheres, you can use the micro catheter technique. But in the internal iliacs, again, you can use this. So this is afterwards. Here is stent grafts in the damaged common iliacs, and as you can see, there is now no more bleeding in the pelvic area. So stent graft at last. There are a huge amount of different types and models, but basically you can choose between balloon expandable. That means that the stent graft is mounted on a balloon. You inflate the balloon, and the stent graft will expand and keep its shape. You have a high radial force, but you lose in flexibility. You can also have self-expandable stents, which have less radial force, but they are superior regarding flexibility and reach the area in vessels that are very tortuous. Here is a classical traumatic aortic rupture, I would say type 3, at the classical point in the isthmus area. It was a man had fallen down from a ladder, and you can see the angio here. We used one single gore stent graft, and once released and the subclavian artery recovered, took care of the problem. You can see the pseudoaneurysm is no more filled there. Fast procedure, rather simple. Another stent graft.
Martin, I'm sorry, can we go a bit faster? It's
Yes, sure.
Great, but Joe is waiting.
Sure.
Just a bit faster.
Yeah.
Thank you.
Severe hemorrhage due to pelvic surgery, orthopedic prosthesis, extravasation. You can see the hypovolemia makes the arteries very thin. You put in stent grafts, and the extravasation is gone. You have to over-dimension the stent grafts so that they will fit, even though the patient get normal volemic later on. Gunshots in a 39-year-old man in the head and neck region, bleedings from the subclavian artery and from the brachiocephalic bifurcation. You can see the angio here, subclavian artery extravasation, and from the bifurcation of the trunk. Here is a Viabahn stent graft, and in the trunk, 2 Viabahn stent grafts put in a sandwich style, going down in the brachiocephalic trunk, from there to there, and there to up in the carotid artery, and the extravasation is gone. Okay, we can leave the last case. So that's basically what I had to say. Thank you, Chala. I'm sorry for
No,
taking
it's
time.
amazing to hear. But I just got now an SMS from Joe DeVos some minutes more, so I thought like this. There is coffee here, and we can take coffee somewhere, and we continue directly with the discussing with Joe, and then June, Victor. Take coffee, enjoy. You have more questions later.
So he asked if you could send him to Sweden or whatever. Yes. They have to see once. And it's the same as they come to
I know.
Risken är ganska liten. So you're saying that we should also pay for it?
No, not just on a complete we can arrange somehow. I think this should have
It would be great. Yeah, of course. Just unfortunate. Do you have a what language? Yes. There is a website where papers there in the internet. You take a paper with white box.
So what we should offer them is that we service their
So just leave it. It's just because yeah, I'm just
I think here. I know. Okay, let's see. Hi, Joe. Great, nice to see you. We do like this, like we gather them. So you're online, we see you. No problem, I can gather the people here, and then I will present you. Okay, you hear me good? Okay. Can I hear you? Can you speak? Yeah, but I will change to another speaker. Everybody,
Joe, good to see you.
everybody, can you gather? We have Joe online.
Good to see you. I'll see you on the screen.
We're fixing now the instruments here. And I will gather this. Could you see us on the GPTM site?
I did. Works very nicely.
Okay, we are not showing the PowerPoint doesn't, we don't want to show the pictures, you know, we want to get the people are, and let's get the people, and then you're on, we see you now. Okay.
Hello. How are you? Yeah, how are you? Here at East Meet. I'm sorry?
Oh, check that. Wait.
I can hear you, I can't see you. That's okay.
It's coming. Great. We will try and see how it works. In the worst scenario, I will call you on my mobile phone.
That'd be fine.
All right. Everybody can come in, please. I would like to present Joe's boss, and I would like him to present himself now live from the US. Can you hear us?
I can.
Oh,
Thank
great.
you for having me.
Oh, great. Well, you are dealing a lot with this Reboa, the new kid on the block, some important major studies, and you've been working in places doing it, and now in California, if I'm right. All
Yes,
right.
we are now at the University of California, Davis. We're rolling it.
All right. And I know you're an experienced guy and working for the military or the Air Force or...
I am the Air Force, yes.
Okay. Now it's a bit paused, now it's again. Joe, I thought that we'll discuss a bit some things about Reboa, and as we said, we will speak about your opinion and the role of Reboa in trauma. We have here trauma people, vascular surgeons, invasive intervention radiologists, and you know the focus of EVTM. Can you hear us? Oh, we will see if we can solve it. We're trying to solve it. Yeah. We'll try to solve this and this. No. Okay, we will see if we manage. We will try to solve this. If not, we will speak with him with this speaker.
No problem.
Okay, you hear us. Great. Maybe we should close our camera right now. Close. Okay.
Okay.
You hear us. Great. So we're talking about the role of Reboa in trauma. Can you tell us what you think?
Well, I think that role is certainly expanding, and it may be different in different areas of the world. There's a significant amount of enthusiasm in the trauma community in the United States regarding this topic. And certain centers, in particular, University of Maryland Shock Trauma, University of Texas in Houston, and a select other few centers have really taken off and embraced Reboa. I know at Shock Trauma, they no longer do resuscitative thoracotomy except for penetrating injuries to the chest. As a general rule, there's always exceptions there. But I think there's a lot of excitement about defining specifically what the role is in trauma, and I think there's some work to be done to match the enthusiasm with the capability.
Okay. How do you see the role of Reboa? What kind of injuries would you use this to use Reboa? Can you give us the scenarios you think you want to use it?
Sure. I'm particularly fond of this, what we call the Zone 3 deployment, which is the bleeding from pelvic fractures. I think it supplements well kind of the traditional algorithm of external fixation plus minus pelvic packing, or in some instances proximal vascular control through a laparotomy. I think it provides a very elegant and simple solution to temporize those patients. But the reality is that it's been used successfully for a variety of injuries, both penetrating and blunt, particularly below the diaphragm. And I think that as we continue to move forward, we can really start to refine the algorithms that include it more effectively.
Okay. Before we go to some other questions, I want to ask you, who should do Reboa? We spoke today with some of our colleagues, here in Scandinavia. The people who can stick to get access maybe very fast is the vascular surgeons, of course, intervention radiologists that are not there also in the ER, mostly in the acute cases, and of course the intensive care doctor, which comes always to these calls. Who should do it in the US? I know the trauma surgeons are interested. Do you have any views on this?
Well, it's a great question, and one that is certainly discussed actively, and will likely in the United States be discussed more actively as we move to smaller profile devices, some of which you've had access to in Asia and Europe, that we're just now kind of arriving to down to the 7 French capabilities from larger bore 12 French capabilities. I certainly think that the largest embracer of this technology, and the one that makes the most sense in terms of low-hanging fruit in the United States, is the trauma surgeon community, because they're there at bedside when the unstable patient arrives, by virtue of the way our trauma system is set up. The question will become, and certainly interventionalists and vascular surgeons, this is something that is inherent and makes sense to them is once they've had some familiarity with it. I think some training has to take place regardless of who is going to be performing Reboa, and one of the interesting discussions that I anticipate will take place in the next couple of years will be, emergency room doctors. Will this be a skill set that they can utilize? I think the answer on that, I think anyone with appropriate training and appropriate skill set, regardless of what the name on their name tag says in terms of their role, should have this and can have this capability. It just comes down to appropriate training.
Okay, it comes to the next question. As I see Sammy entering here the room, he was a bit late. Sammy is one of the group in London that has been doing the pre-hospital Reboa in London, as you know, the London guys. Just enter now, and this would be a great question. Do you think it can be done in the field? Do you think it can be done in the military? Todd and others has been working on this, and your colleagues. How do you see this? Is it applicable?
I think it certainly has application. I think we have to, as you may or may not know, there's a variety of different platforms within the military for casualty initial treatment and evacuation. Some of those have expanded skill sets, including physicians in the various earliest phases after injury. And I think that our British colleagues are certainly showing us that this can be effectively utilized, whether it's on the curb in London or on the battlefield as part of a MERT capability. In the United States, we're continuing to have some early discussions about that. How far down the skill set range do we go in terms of, are there advanced medics that we can teach this skill set to? Is it smart to put that in their hands? And I don't know that we've resolved that completely at this point. But it's certainly discussion needs to be ongoing, and I think our British colleagues are, in my opinion, showing us the way with their civilian experience, but I think the potential for military applications.
I would love to hear what Johnny and Sam has to say. Just one short thing before, limitations of RIBOA. Well, what are you afraid of? How do you teach the residents? What are you afraid of?
Well, you know, we have been hampered by the requirement for larger French access with our typical Kodo reliant balloons that we have been forced to utilize until the recent release of the prior ER RIBOA balloon. I think in the past, and certainly there's some published experiences out there that highlight this, the risk for the limb ischemia is a big concern for us. But one of the things I have to commend our colleagues at University of Maryland who teach the basic endovascular skills for trauma course is that they really emphasize that the removal of the sheath and the examination of the limb thereafter should be considered a routine part of the procedure. And I think if you approach it in that fashion and are mindful of the risks, then the limb ischemia becomes hopefully I know in our recently reported data from the aorta data that we established through the American Association for the Surgery of Trauma, at least in our first 47 patients, we've not seen any limb ischemia, which I think is encouraging that we're teaching the right things and the right approach in that regard.
Okay. Comments? Sam, Johnny, the others. And we have the camera on, I will close it if it's bad connection.
Hello, I'm sorry for being late. I've been watching you all the way online. On the train.
Just speak louder, Sam.
Yes. Well, we think it can be done, and we have done it pre-hospitally, but there are lots of challenges. So the environment is uncontrollable. I imagine, of course, the military environment is even more uncontrollable. But pre-hospitally, it's definitely more difficult than in hospital, I think. And what we're finding is that probably the biggest things, like you guys have been stating all morning, is the vascular access, the first stage of vascular access. So as to who can do it and who should do it, I mean, we don't really know the answer either. We put it in the hands of ED physicians and anaesthetists and intensivists. We're all pre-hospital physicians, but everybody is trained to quite a high level and trained quite intensely, in the aspects of reverse. But the point being, I suppose, that even then we have had some cases where we've not been able to get the catheter in and get access. So to me, it says that if a consultant anaesthetist or a consultant intensivist or a consultant in A&E can't get ultrasound guided vascular access or even a cut down, it will be hard to train somebody who's not so familiar with the technique to do it. Not impossible, but even harder. And the other big thing, I think, is recognizing the sick patient, because like you say, it's not without its risks. But so there's something very big about someone who knows a lot about trauma being able to recognize the difference between hypotension and catastrophic shock. Someone who's really going to die without it.
We would love to hear a bit more. Thomas, any reaction?
Yeah, I have a comment to you, Joseph, about this concerns about limb ischemia. I cannot see that limb ischemia should be a problem. We are talking about an introducer that is between 3 to 4 millimeter in a normally 8 to 9 millimeter. Can you follow me?
Joe, can you hear us? It will come back. Continue speaking. Or
I had a question for you.
Yeah, it's coming. I'm sorry for this technology problem. Joe, are you back? Part of reality. Do you hear me, Joe? Can you hear me?
It's the same thing with nice guy.
I know. That's reality, but we'll see if he hears us. So I thought it would be nice that we see each other, but I'm not sure. Do you hear us, Joe?
I can. I'm sorry, I missed the last question.
Yeah, Thomas, continue.
Well, yes, I have a question. You had some concerns about limb ischemia. Do you really think that is a problem? I don't think, because we are talking about an introducer that is between 3 to 4 millimeter in outer size in a vessel that is normally 8 to 9 millimeter. If you would, in my hand, give me a device, a 12 French device for an endovascular aortic repair, and I would say, oh, this is great. This is really low profile. You know, I don't think you should have concern about that.
Well, and again, in your hands, I don't have concerns.
Oh, thank you.
I think some of the challenges are, especially as we discuss, our ER doctors going to be putting this in. There's a generation of trauma surgeons in the United States that have less experience with vascular repairs and vascular concerns. It's just the way training is progressing into O5 programs, and that skill set is diminishing. And so I think that particularly as you have ER doctors or discussions about ER doctors putting it in, that is a potential concern. I don't think it's the placement with the entry. I think people put the balloon in and think, oh, I'm doing great. I've got the Ribula up. I don't have to worry about a thing. And they forget 5-6 hours later that they've had this large sheath in. And I think that's where the danger could take place. But you're absolutely right, sir. In an experienced practitioner's hands, I don't even a 12 French device is certainly not. But that's what scares the trauma surgeons here in the United States is the 12 French size. Okay. And a lot of that is born out of some of the literature from June's very familiar with on the Japanese front, but with the one paper in particular, and I forget the first author, where they had 3 limb losses.
Yeah, and we have here Victor. He had an interesting case, and I think maybe it's not on the acute phase. The problem is maybe you mentioned that these introducers are in place. Maybe you forget them. You think about other problems, maybe intracranial bleedings or whatever, and maybe someone might forget this. Victor, do you have a comment on this?
So if I
speak loud, please.
Will I be able to report my presentation, or
you can show it later on? But if you can just say
I
a word on this.
I will demonstrate pictures. But the idea is, we were asked by anesthetists because they were really encouraged by the effect of the ABO to leave deflated balloon in place. So we forgot this balloon in place in thoracic aorta. We thought it was deflated completely, but as Martin showed that even 2 or 3 millimeters fluid inside the balloon means 9 to 10 millimeter in diameter. So it is pushed down by the restoration of the flow into the common iliac arteries. So resulted in disastrous consequences, leg amputated. So, because probably that was the main reason of death of this patient.
So this is of course a problem. And we in the registry we have now around 62 patients, and there are 30 more coming in now that we have already, and we have 1 limb lost, if I remember right. But of course it's an issue. Any other comments, Johnny Morrison?
Hi Joe, I was curious as to the experience you've had at shock trauma, as to how that's changed how you obtain definitive hemorrhage control. One of the things I've heard talked about is that rather than using this as a bridge to definitive hemorrhage control, it's seen a reduction in things like preperitoneal packing. I was just wondering if you could share any insights into your experiences as to whether it's changed how you obtain definitive hemorrhage control in these cases.
Yeah, it's interesting to see the adoption, and I'm no longer at shock trauma, but I'm in a meeting here at the Eastern Association for Surgery Trauma discussing with some of those colleagues. and I can tell you, I can speak also that our registry for the AAST. I think what you see there is that people have a much lower threshold. It makes sense, right? People have a lower threshold for placement of a balloon in the aorta than they do for ED thoracotomy. So we're utilizing aortic occlusion, where the same effect is achieved with the occlusion element at a much lower threshold than we would have for resuscitative thoracotomy. And I don't know that we completely understand all the ramifications of that with regards to the ischemic reperfusion injury, particularly for zone 1 deployments with the intestinal ischemia reperfusion. So it's going to be interesting to see, and I don't completely have an answer for you on that yet, Johnny. We're up to 90 patients as of yesterday in our registry, and it continues to grow. And I think as all these registries start to mature, we're going to learn quite a bit.
I have to say that Martin, please.
Martin Delle from Stockholm South General Hospital. Do you see any contraindications? For example, if you have pericardium, cardiogenic shock, is that something you should be aware of?
I think that is certainly a concern, and that's the way most people are thinking. It was interesting from our registry when we included all occlusions, whether it was by a clamp through a resuscitative thoracotomy or a REBOA. It was interesting to see, you know, it's a double-digit number, the number of patients who had a uncontrolled bleeding source above the occlusion. So figuring out a way to rapidly, and then certainly you put a clamp or a balloon below the occlusion, you're going to exacerbate bleeding above it or issues above it. So that's another kind of important element to emphasize to people is that your balloon below your level of occlusion may actually exacerbate your bleeding. So those are, and of course the cardiogenic concerns that you raise, they're not well thought out, but I think most people agree with you in that regard.
What do you say about penetrating and blunt trauma? In the registry, in the primary look that we had now, it seems that penetrating injuries had much higher survival. And I don't know exactly how to explain it. Can you tell me what you think? Can you tell us what you think in your registry and your experience in penetrating versus blunt trauma in REBOA?
Well, in our initial look at the first 47 patients, we didn't find any difference in mortality between the two groups, resuscitative thoracotomy versus REBOA, which on some level was a little concerning, but on others, you spoke to that we need more data. I think shortly we'll reanalyze that data at 90. The real value of our study and some of the additional criticisms here in the U.S. was the time it takes to do a REBOA. I mean, I think most seasoned, I live in a country of guns and knives and a lot of gun and knife clubs. And I think that an experienced trauma surgeon in the U.S. can perform a resuscitative thoracotomy pretty rapidly. So a lot of the older, more experienced trauma surgeons at the meetings when we're talking about REBOA would claim that they could get into a chest just as fast as they could by placing a REBOA. And what we found was that with some experience at the centers that are doing it, the time is equal. And I think that's another major criticism of REBOA, at least on this side of the ocean.
Mm-hmm. Any other comments by now? Some thoughts about it? Yeah.
Per Skogman, Swedish vascular surgeon. I have had some contact with the Norway. Norway is a very hilly country with long transport times. They have had some centers, mainly in the capital, that have had quite a bit of experience with REBOA or AVO in gynecologist scenarios. So they have trick deliveries with bleeding in the mother, and they had very good experience, and they have had very long occlusion times, and they've had their way of coping with that is intermittent occlusion. So now they are taking the technique out broad in the pre-hospital civilian medevac helicopters in the whole of Norway, and they are all equipped with, or they have anesthesiologists in the helicopters. But their idea of coping with time, because they said that if we are going to put in AVOs pre-hospital, it's the time factor. We are not getting into the hospital in less than 30 minutes, more like an hour. but they are talking about intermittent occlusion. Do you have any ideas? You talked a little bit about it, but do you have any ideas of comparing partial or intermittent occlusion?
I think the technology is going to continue to improve, and one of the things that we're studying in the Air Force presently is a concept that we've called EVAC, or endovascular variable aortic occlusion. So devices that are balloons that are smarter, even tying into smaller electronic devices that can be attached to the balloon, that can measure pressure above and below. So as the pressure, it still seems to me that the concept of intermittent occlusion is still very crude. It really relies on our fingers on the syringe. And I think that we can perhaps, as we move forward, become smarter about that. Some of our research is focusing on how do we utilize existing technologies to measure the pressure above and below the balloon and let off the balloon just enough to mitigate some of the risk of ischemic reperfusion injury distally, but maintain the perfusion to the proximal organs, the heart and the brain, that's really required. And I think that's probably the next echelon. Will become more refined with it. So I think variable occlusion or intermittent occlusion is the next area of examination.
Okay, Thomas.
Yeah, Thomas Larsson once again. I wonder in your country with, as you say, guns and knives, how many patients, considering the skill set is there, how many patients could actually benefit from having an occlusion balloon in place, inflated or not inflated? What's your idea?
Well, that's a very interesting question, Dr. Lazan, and as we continue to define the indications, maybe that'll help us answer some of that. I don't know of anyone in the United States that has done an examination looking at patients who had possible indications for Reboa.
But this was done by Johnny Morrison in, am I right? Johnny did
in England and Wales.
In England,
in English Wales. A little less violent than the American.
Or sorry, Joe.
No problem. But I think that Johnny's study really serves as an excellent template for what could and probably should. You've given me a research idea, to be completely honest with you.
Shit, I wouldn't have had you online today. Continue, Joe.
No, I think that's an excellent question, Dr. Lazan. I think that in the United States, the tendency has been to compare Reboa to ED thoracotomy and or resuscitated thoracotomy as really it's either better or it's not better. And I think the question is not that simple. I think Reboa is useful in situations that we would not traditionally utilize for resuscitated thoracotomy, including some of the gynecologic example was raised, but pelvic fractures that are perhaps not in profound extremis, but are continuing to have transfusion requirements en route to the interventional suite or the operating room. So there's a lot of work to be done. It's an exciting time to look at this topic, and it's interesting to see the trauma community wake up to this concept that has been, so elegantly introduced to us through the vascular world and their experience with ruptured aneurysms. And I think it's really an exciting time to look at this particular topic. We have a lot to learn from everybody, from Johnny's work in some of his registry stuff, our British colleagues in the UK, the Japanese colleagues in June and his partners, and with the work that you're doing right there with the group that you have assembled in terms of training and looking at outcomes. So it's an exciting time of collaboration and a lot of questions that hopefully we can answer.
Can you just give us, before we finish, some thoughts about the whole concept, what we call the EVTM? Not only the Reboa, so how do you see the potential use of other devices, balloons, coiling, embolization, whatever, in the military, in the trauma scenarios?
Yeah, I'm obviously a fanatic when it comes to that, in terms of my belief that the endovascular technologies are going to continue to move forward and supplement and replace to some degree a lot of the things that we do for vascular injury. And that role is going to change, and I think it takes collaborations like what you're doing there to explore where those trends should go and what kind of advancements we can make. So I salute everything that's being done. That's why I'm happy to be part of this.
Thank you very much for your time. We will see if we can take some more questions later on by mail and etc. But thank you so much for your time, Joe. We appreciate it, and we thank you. And you can continue watching us live now.
Well, thank you very much. It's been my pleasure. Have a great course.
All right. Thank you so much. Okay. We rush forward. Jim.
Hello everyone, I'd like to talk about damage control interventional radiology and Presto concept. And let me introduce myself first. I'm from Japan. I belong to St. Mariano University Hospital, which is located 20 kilometers from Tokyo. And I'm an emergency and trauma radiologist belonging to emergency department. Doing diagnosis and interventional radiology, but nowadays I do more diagnostic and making strategy kind of thing in trauma scene. And I'm a Secretary General of Japanese Society of Emergency Radiology, and also doing a private society named DIRECT. It is diagnostic and interventional radiology in emergency, critical care, and trauma. So it's we do this with Tomo here. And so, as you know, CT and interventional radiology is a very useful screening tool and one of the very effective therapeutic options. But in a major trauma guidelines, it's not recommended to use those for unstable, hemodynamically unstable patients. It's for stable patients they recommend. But we know or we believe in power of endovascular management, and we like to, or we believe that we can save more unstable patients with endovascular management. But how? We need to have a right concept, meaning it is time is life. Because 1% of unstable patients will die in, every 3 minutes. Meaning, if we lose 30 minutes, that means we're going to lose 10% of unstable patients. So we need to have time-conscious protocol for unstable patients if we want to use CTs and endovascular techniques. So if we look at the whole process from arrival to the hospital to IL. When we get the patient, we do primary survey, and if we can stabilize the patient, we can transfer the patient to CT and scan the patient, and after that, we transfer the patient to the EEL, and during the process, we diagnose and make a decision. And after the decision, we transfer the patient to the angio room. But during the process, according to the conventional concept, the IR team is activated here. We get an extravasation and we need your help, so please come to the hospital. Then they say, okay, we're going to go, but you need to wait 30 minutes or something. So this is a conventional method, and most hospitals in Japan is like this. But we need to save unstable patients. So in that situation, we need to have different concept. That's why we suggest another newer concept named prompt and rapid endovascular strategy in trauma occasion. As you know, press means, in Italic, faster, or in a music, it is technical term to play fast, or in American, I don't know, but the magician said, ta-da, kind of thing, presto. So it means it can include those kind of meaning. And in this concept, if we look at the whole process, I'd like to show you explain this concept, dividing into 3 stages, what we should do. On the first stage, we have to activate IR team before patient's arrival, like this. So this is in our institute. We are the radiologists also come to the trauma resuscitation unit prior to the patient's arrival, waiting for the patients together with the other doctors. Here you can see this is me and this is Yuri there. And we worked together in the past, so that's why we are ready the patient prior to the patient's arrival. And it is important, all about access. It's important to put arterial cyst during primary survey. We think it is a part of primary survey, so we put the arterial cyst. This is the initial portable chest X-ray, but before the pelvic X-ray. But before the pelvic X-ray, we've already put the cyst bilaterally in the femoral arteries. So we do this if the patient is unstable. And it is also very important prepare for transfer prepare for transfer to CT during primary survey. We ask the CT technologist to arrange the route and remove the metallic or unnecessary objects during primary survey. Then we can take the patient to the CT scanner when we want to take the patient. But if you do not do this, it takes another time. We are going to waste time to prepare for transfer. So it's important if we want to scan the patient. And on the second stage, it's important to have, specific CT protocols for unstable patients. I think it's important even for unstable patient to have CT information, because we want to make right decisions. So it's important to have CT, especially for unstable patients. So that's why we need to have specific CT protocols for unstable patients. So if the patient is not that unstable, so we do scalp view and we make a plan for the head, neck, and the body. And we scan the dry head without contrast material, and then we scan twice arterial phase and delayed phase for the whole body. This is for not so unstable patients. But it takes 12 minutes to 20 minutes from the time to entry to the CT room to the time to getting out of the room. It takes 12 minutes to 20 minutes because you have to take the patient on the scanner, arrange the routes, and you have to put the patients on the center of the scanner, and then we have to make a planning scan. Then after that, we have to make a plan, and then we scan the patient, and we take the patient off the scanner. Then we have to go. So it takes time, but it's important to shorten the CT room stay time.
Let me ask you a question. Sorry, is it acceptable, to let 20% of the patients die during that time?
Yeah.
In the CT.
Yeah.
Okay.
Yeah. So that's why we need to shorten the time. So if the patient is not so stable, unstable patient. Yep.
I'm a trauma surgeon, and this is something bothering me a lot here. We have a very strict rule: no hypotensive patient can go to the CT scan. We need to decide, and I think that this is the crucial point about the RIBOA here. Is maybe we have the time to decide what to do, but hypotensive patient never ever will go to the CT scan. You need to decide if he's stabilized or she stabilized in the emergency room, then a angiography or a CT angio or whatever. But if the patient is unstable, you need to decide when and for what to take the patient to the OR, and not to the CT scan.
Yeah, I understand that concept, and it is the goal.
How you can respond for this in your hospital? Like hypotensive patient with 70 systolic blood pressure will go for 20 minutes to the C, or maybe 25 or 30 minutes for the CT scan.
Yeah,
and he's bleeding from the spleen or the Yes.
Is that so dangerous if they have 70 in pressure and they are awake? We treat the ruptured aneurysm by giving them no fluid, and we take them to the CT. I think the benefit of the CT is far much more than the risk of it. Our concept is a 100% EVAR, and I would say I'm not. People say they are in shock. What is shock? Can you define shock?
There is a huge difference between ruptured aortic aneurysm with retroperitoneal bleeding than intra-abdominal bleeding from spleen or liver. I think this is two different clinical situations, totally different.
Well, it's not. I don't agree with you because not all of the ruptured aneurysms are retroperitoneal. They have, in fact, also blood in the cavity. They have penetrated to the fascia.
But
I'm not sure that it's so dangerous.
I think it's a very amazing discussion. I would love to continue it. If June continues and direct afterwards, can we continue this discussion? Is this okay with you guys?
Yeah.
It's very important, very, very important.
Yeah, I welcome the opinions. And when we got the unstable patients, we put the balloon in, and then, but still, we take the patient to the scanner. But the patient's blood pressure below 70, we don't take the patients to the scanner. But if we can, if we use the balloon and when we get the blood pressure about 80, then we can take the patient to the scanner. But that is our concept, but you do not have to agree, and because you are the surgeon, I'm a radiologist, basically. But and so if we have severe cases, we do not do separate scanning. We do one scan. So still we need to have 9 to 12 minutes, meaning 10 minutes. But if we can have shorter time protocol, it's scalpless scan. So we do not do the scanning for the planning. We put the patient on the scanner, then start the scan, and we give the contrast. So with this scan, we can make the CT stay room like this, 7 to 9 minutes, but it is still too long. We're going to lose, 2% of patients. So it's too long. So we, our team, routinely do the practice, the drill. We try to make the CT stay room shorter. So once a month, every month we do. We call the whole team and we try to make it shorter. So this is the video, but it doesn't. I don't know if it works or not.
Yeah.
Okay. No, it says. Oh, something. So it doesn't work. So it's okay. So
I will fix it later that we can see.
Yeah. So after the training, with this no scout scan protocol, we take the patient in the CT room and scan the patient and take out the patient within 3 minutes and a half. So we just can finish the scan within 200 seconds. So I think it can be reasonable. Even with this protocol, with scout view, with planning scan, we train them, then we can finish it, the CT strip from the time to entry to the getting out of the room. We now we can do it within 5 minutes. But I know we still gonna lose 2% of patients, but I think this is the best for us. So, but I think if you measure the time in your institute, I think you're gonna know you spend more than 5. Like I think you spend 15 minutes or something for the scanner, but less than 5 minutes you can do it. So if you cannot allow 5 minutes, then you have to take the patient to the OR. But if you can allow 5 minutes, then you can scan the patient. So during the scan, we also have to evaluate the images. So, but there are a huge amount of images, but we do not have time to evaluate whole thing. So we need to do focused assessment. So we have to do the major trauma thing. We do not evaluate in detail in this situation. So it will be done in 3 minutes. So it will be done during the examination. So if we can finish the evaluation during the examination, we can here make a decision and we can take the patient directly from the CT room to the OR or to the angio suite. So that's why it's important to do focused assessment. So we always evaluate those things and how easy and how severe, because if we can evaluate those, so we can, which injury should be treated first, or which injury second, which injury third. So we can make decision the priority. So we have to start with the easy and the most severe injury first, then we go to difficult and less severe injury. So if we cannot, if we see the difficulty, but the severe and difficult injury, then like here, so we have to, change the strategy, like putting a balloon and do not embolize, but put the balloon in and take the patient to the OR or something. So, but with focused assessment and shorter time scan, we take the patient directly to the right place, angio or hybrid room. Then we can do the right management with right strategies according to the CT information. Then this is the example what we do in the ER using CM and doing the head sting and the angiography at the same time after the direct transfer from the CT. And the interventional radiology, we also need to understand the damage control concept. So in this damage control concept, we call this DCIR, saving life is primary concern. The basic embolization concept, you have to go there and embolize it selectively. But in this concept, you have to save life, not the organ function. So you have to do extremely time-conscious procedure. So in this DCIR concept, you have to finish single arterial embolization less than 10 minutes, meaning if you have a pelvic fracture and splenic injury, you have to embolize 1 to 3 arteries in 30 minutes from the start. And so this is the example of a splenic injury. It's not that bad bleeding, but you can finish it in less than 10 minutes from the catheterization to the end of confirmation arteriography. And you have to skip diagnostic arteriography as you know. For example, if you have a pelvic fracture, all you have to do is embolize bilateral internal iliac artery. So you do not have to have whole pelvic arteriography before embolization. You have to go directly to internal iliac artery on the back side, and then you go another side. Then after that, you can do the confirming pelvic arteriography. You do not have to do diagnostic arteriography. If you have CT, you do not need to, because you know where the bleeding is. And you have to allow non-selective wide range embolization, because as I told you, we'd like to go to embolization selectively, but in the case of unstable patients, we do not have time, so we embolize proximally, or we can put the balloon in if we do not have time. And also NVCA, it's a kind of glue, is one of the preferable embolic agents, because gelatin sponge or metallic coils act dependently on coagulation, the normal coagulation status you need to have. But most unstable trauma patients, the patients can be a anticoagulation status. So in that situation, it needs more embolic agents, or it takes more time to embolize. So in that case, we use NVCA because it acts instantly and it acts independently on the coagulation status.
It's like a super glue.
Yeah, it's a super glue. It's obvious. It's actually a super glue. So if we use this is we are trying to embolize the internal iliac artery. Then if we inject small amount of NVCA, it is embolized instantly, less than, it's like 30 seconds. So it's very useful in a severe trauma situation. So we can, if we can do faster enough, then we can embolize the bilateral iliac arteries less than 10 minutes. Sometimes it's like 7 minutes or 8 minutes for bilateral pelvic internal iliac embolization. And we have to, it's also important, we have to be flexible. We changing devices, operators, and methods. So if it looks hard, if we cannot do good enough, so we have to leave the balloon and we change the method. We need to change to the angio to operation kind of thing. And it is also temporary balloon occlusion is one of the important method. And during the DCIR, we need to do operator assistant and conductor, and we have to create OR or IC-like environment. In the OR, you can ask for help for anesthesiologist. So even in the interventional radiology, we ask anesthesiologists to help to create safer or less invasive environment for the patient. So if we have a conductor outside the angio room, so the conductor can discuss with what we are doing or what we should do next with trauma surgeons, and we can make the conductor can give direction to. We have only 5 minutes for this embolization, so you have to leave the balloon now, or you can continue, or you can give up. Those kind of things he can give these advices, or anatomical information also can be given by him. And under this concept, I think we can save more unstable patients, because under the concept of the Presto, we cannot shorten the primary survey, but we activate our team earlier, and we can scan in a shorter time, and we evaluate and make decision during the examination, and we can transfer the patient directly to the right place. Sometimes it should be over. And if we can save time, we can save more patients with using radiology kind of thing. But if you don't have 5 minutes or something like that, so we skip those processes and we take the patient to the OR directly from the ER. So I don't have to repeat these things. So if you have any interest, or if you have any more interest, so this concept is already published in a French journal, Diagnostic and Interventional Imaging. It was published in 2015, so if you have any interest, you can get it. So thank you for your interest.
We will open this discussion. This is a very important point and fundamental point in trauma management. And we enjoy going against the rules, And just a small thing, we're a bit behind the time, but it's calculated. I calculated, so don't be worried. We'll fix it. Thomas, first.
We know that you always calculate optimistic. That's good.
He's my mentor. This is the guy.
Yeah, I'm wondering about this 5% or something that has not time for CT. Is that not really the patient that should have a CT? Because what you are telling all the time, the concept is, yes, you will lose maybe a fraction of patients during the CT, even a short CT, but the other side of the coin will be that you can be very exactly precise, you can stop the bleeding on the local anesthesia and so on. You do not have to open up the patient until he is totally stable. So the 5%, that's where I think concept of the aortic balloon occlusion, maybe already in the emergency, and if we can find a good concept is that not the patients that really need the CT?
Before I continue, Martin, and then I want to make a comment on exactly on the new CTs that are coming. Martin.
I agree with you and Thomas, because I also think that modern CT scanning has a much higher sensitivity than classical angiography or aortography. You will miss bleedings compared when you do a CT. So I don't see non-selective angio as an option when it comes to find and make evaluation which bleeding should we treat first. I mean, which is the number one problem, number two problem, number three problem. I think that is hard when you do it angiographically. If you see it on CT, you can also see where is the amount of blood or the extravasation largest.
Two comments. First, in the rupture materials, which is different in our ruptures and others, the time for our CT to do a complete CT from the ER to surgery is 14 minutes. We measured it, and it's possible. It can be done. Another question would be, do you do a venous phase? Because I know that we lost some patients because we did not do a venous phase. The other point is we are doing a horrible good CT with a planning, like, and this, and then this, and then we plan it here, and then you move and you're getting crazy, Richard, you know. No, he's not stable, and then you have to put a bit to the right, a bit to the left, and I think it's a beautiful concept that will fit 90% of the normal bodies. You're the radiologist, I don't know, but the normal person, I guess you can do in better, a faster way. Then they're coming, that's why Toshiba is here, and of course Siemens and Philips all have the new CTs. It's called CT on rails. The CT on rails is a normal CT, high definition, multi-slice, whatever, all these names. Completely new, you can use it for cancer, whatever you want. The difference is it's standing on rails. It's installed in Japan in 9 centers, what I know, in Copenhagen, 2 machines, and in Frankfurt. And this is what I know anyway. And the difference is this is your trauma room, the CT is here, but when you say it will come in on the rails, it will scan, it will go back, and you continue. And some companies have also the hybrid room inside. In Örebro, it will be built in 4 years. I think there's something about it. Comments, discussion. Just speak.
I would like to make one comment because everybody talks about the time of a CT scan. I
just speak up, please.
I see it more as a whole trauma protocol because I think you have some concurrent activity and lost time. Because if you're honest, if a whole OR team normally takes up to 10, 20, maybe even 25 to 30 minutes that an OR team is completely ready, especially in a civilian setting. So I think if you even have the time for the adjuncts of a CT, it can give you much more information. If you have a Presta concept which works in your country, it can save your life already. So it gives you information and its treatment. But if you don't have that time, and if you see it from the trauma vision you have, of course, a laparotomy or thoracotomy is the first thing to do. But I think the Presta concept, if it works in time and it doesn't delay the final treatment, is a very good option.
Maybe the magic word is in your institute, with what you have, with the people you have. Honey.
We call the CT the tunnel of death in trauma. I don't. We do the venous phase. It will take something like 15 minutes. The 5 minutes for me looks like a dream. Okay, even that I work in a very, very efficient trauma center with a very high volume of severely injured patients. So I hope that once I can stand on these times, like 5 minute CTs, 8 minutes of angiography of the main splenic artery, and so on. The other question: do you have any data comparing what you are doing, like this CT, very fast CT, and angiography and embolization and so on, with the other group, like this patient that is hypotensive, positive fast in the abdomen, or splenectomy, like for the morbidity and mortality?
Actually, if you have a, positive fast, and if the patient is unstable, if you can take the patient directly to the OR, you can, take the spleen out in 15 minutes, So, you know, during the time we can come back from the city, but we can do anything. So in that situation, you know, no argument is needed, I think. So you need to open with the patient. But you hopefully you will have the data of our paper. That paper I introduced to you is just a paper about the concept, and we've already written the paper with data about the breast concept, but in which we do not have very bad patients in that paper, because it's hard for us to have so many badly injured patients in our country. We have very small number of those patients, and unfortunately we do not, because of that situation, unfortunately we do not have very good trauma surgeons in Japan. So in that situation, it's hard to compare the data between those.
The other question, you thought, and this is something very interesting, that you will participate very early in managing all these severely injured trauma patients. Okay? Like for all of them, from the beginning, they will call you and you will come to the hospital to.
In that paper, I mean, according to my concept, I'm hired in several hospitals. Two of them, we can do this, but the other hospital we cannot do this because of the less passion of radiologists.
But I think it's a great point, because as Rickard was asking here, do you want to be called for every trauma because you think everybody should get access?
I'll give you the numbers and please tell me. Okay, we have around 1,300 trauma team activations every year. Okay. So like we will have around 5 to 6 cases a day. So if somebody can like stand, this would be great.
But it depends very much on the institute, and that's, I think, a good answer would be it's a concept, and it has to fit. I'm sure Per doesn't want them to call him in Göteborg now 3 times a day. It's horrible, and maybe 2 times would be for nothing. It depends on the institute. If you work up in Umeå, maybe once a month, maybe once half a year, big thing. I will show you a great case that's done in Jönköping, not far from here. You would do laparotomy or thoracotomy, would do great work. They solved it in another way that you would love or hate. I will show it later on. And they are not experienced in trauma. They have once half a year. I don't know how much, but it depends very much. I've been now in shock and trauma in Baltimore. I asked how many patients are hemodynamic unstable. And you would be surprised. They have 8,000 trauma per year. If I understood right, and I don't know a paper about it, we're talking about 5%, 5, 10. It was Dutch estimate from Megan Brenner. How many are unstable? It's a very small number. And of course, some can live days with a minor, not the dying patient. But I think, in my point of view anyway, it's a general concept. Thomas, you're a radical side of the CT. This is what you taught me, CT. And I don't remember that we lost the patient in the CT, bleeding, blood pressure 40. We did a rupture 2 days ago. We did a rupture 5 days ago, 40, 60. And the majority on high, am I right, Thomas? Yes. The majority. And by the way, access, when I have a problem, they solve it. I call for help, of course. And all the rupture material are done in our institute, all 100%, and published also with blind puncture. So there are a lot of things to learn from the vascular side and how to implement. It can't work in every hospital. It cannot work in your hands, but your hands. So it should be considered carefully.
I think the key point is exactly as you say, is what kind of place you're working at. In your hands, the open surgery is golden. In our hands, maybe the vascular. And this will give you another tool in your kit box to choose from. So depending on where you are working, what kind of experience you've got, it's not the way good.
Before we go on to Victor, the London guys, any comments on this? What do you think about the CT?
Well, I guess the question is whether you need to answer a question or not. So if there are, like you mentioned, a patient who's fast positive with a splenic injury, who's desperately shocked and has an injury that's consistent, a mechanism consistent with injury, you don't really need a CT to answer a question. Or they're stabbed in their heart and they have a tamponade. You know where they need to be, so you don't need a CT. But we do CT some unstable patients if we think we need to answer a question that will make a difference to the patient, that will change the cavity you open, or actually maybe not even lead you to open a cavity. You might get away with IR rather than thoracotomy or laparotomy.
I've been taught by the IDF, good or wrong, but I'm a bit like this. When I see a knife in the stomach, I'm a bit less worried. I don't know. Just a comment. I'm sorry, Thomas. I see a knife, so I see the knife. I don't know. Stupid me. I know the knife. Probably it's here. Probably it's not here. The guy jumping here that I had jumping, he took a knife. He did like this, and he fell from this. I don't know how it's possible, but he fell from the third floor. Where I don't know. I didn't know where to start. What's the major injury? And that's my concern. Thomas.
How do you know that it's just a ruptured spleen? How do you know that?
It's very difficult. So I suppose the example I'm talking about is maybe a cyclist who falls on his handlebars, ruptures his spleen. You know, someone that's very obvious and has an obvious indication.
Well, we are talking about outliners now.
Yes. Whereas, but in your average blunt patient, let's say someone hit by a car or a bus or fallen off a building, again, it does fit your institution and you have to make a decision. Everybody's decision will be different depending on who they've got upstairs, how far is upstairs, how quick the surgeons are, how quick the ED is, and how sure you are of which cavity to open and how quick you can get a chest X-ray, pelvic X-ray, fast scan. If you've got all the answers and you know they will be ready straight away, yes, go to theatre, but there are times when you know that actually they're not ready and you need more answers.
Okay. So, should we go on, Victor? I'm sorry for the delay, but I think it's interesting. Thank you, John.
So probably the next step will be CT integrated in the helicopter.
In your car.
Yeah. So I'm proud to have I think I would be as short as possible with this because we've been discussing it all the day. And I would like to share our experience focusing on these positions, but mostly pay attention to hazards, problems, challenges, complications. So for you to avoid this every time when you struggle with this. So this is a short history, which was very nicely described. So the two main goals of aortic balloon occlusion is to maintain systemic blood pressure and organ perfusion, and to stop any non-compressible trauma hemorrhage. So what we get by means of balloon occlusion of the aorta is a bridge to definitive hemorrhage control, either surgical or interventional radiology procedure. So this leads to temporary stabilization of the blood pressure, and we buy some time to make a right decision at the right institute, what the best way to deal with this patient in your specially institute or facility. Whether you get to CT, get some blood for transfusion, or set cell saver up and perform any other different procedures. This is a very well-known paper from Stannard and co-authors describing 3 zones of aorta. I would add one more zone, null, so I will show you a bit further about this. And the main indications we use in our hospital, there are many algorithms. We are not very concerned about revealing aortic injury because we are pressed for time, and usually we have no time to understand what's going on in the patient. And we perform it in traumatic cardiac arrest upon admission if so we suspect abdominal pelvic trauma is prevailed, and if the patient is highly hypotensive, less than 70 or 80 in case of fast positive, or if we suspect a severe pelvic injury. So this is an algorithm of ABO will describe five main points, and I will follow all of them. So if you have arterial access already done before that, when we put microcatheter in the femoral artery, that's very nice. We can change using a wire. We can change upsize our sheath to appropriate one. But in pulseless arteries, we usually take the patient with severe hypertension. We use femoral cut down. So, or for example, in this case, when no pulse can be caused by severe hypertension, but this is a patient I tried to perform ABO twice. I opened right groin, so it was completely atherosclerotic with a guy of 70 years old, and I could get venous access instead of arterial just for infusion. Then I went to another site, and that was the same story. And afterwards, we revealed, this is transradial angio. When we tried to embolize this external fixation, then reperitoneal packing, and we didn't find any source of bleeding or point for embolization. So this, we also should be ready not to perform ABO in such cases. So we should use stiff or super stiff guide wires to support the catheter, and I will show why. Another thing is the sheath. I think so. In the near future, we'll have all aortic balloon occlusion system with a low profile, and so their 12th or 14th sheath will never be used then. But we use 11 or 23 sheath in case of pelvic zone 3 aortic balloon occlusion, and this long 45 to 60 centimeters aeroflex sheath for zone 1 occlusion. There are a lot of balloons. Most of them are compliant balloons, 3 first. Coda is used mostly in the US, as I know. We use Reliant Medtronic because of, we have our elective surgery in different such as EVAR, TVAR, and we are supplied with this kind of balloon. Equalizer, Todd said about equalizer, I think.
You will feel it here.
Also,
we have this.
Yes. And I know in Israel, for example, they use Maxi LD, which is a non-compliant balloon. This one just for PTA, but with a maximum diameter of 25 millimeters, which is also suitable for mostly for zone 3 aortic balloon occlusion, but for partial occlusion also fits. Or the modern systems like ER catheter, which is we don't use wireless system for blind insertion. I think Johnny is one of the consultants to produce this product. I think it's a very nice thing. I never seen it before. Although I used this is Tokai balloon, the rescue balloon. I used it one time for proximal balloon occlusion of the brachiocephalic trunk. This is a picture I taken for our students, show how it works. This is a 7 French catheter, very nice. Then we need to insert this balloon when sheath is in and it is in appropriate diameter. So we usually do it blindly with radiographic control because of the reason I will explain a little bit further. Fluoroscopy, I think this is an ideal situation when you look at the balloon, you're inflating it with a mixture of saline and contrast medium, and you see where you are exactly. Another way is ultrasound. One of the recent paper about micro bubbles which can be inserted into the vein, and then we can position the wire or balloon using an ultrasound probe. Then this is a bridge to the main procedure. We inflate in the balloon and we buy some time, let's say 30 to 45 minutes for zone 1 occlusion and 1 hour and a half or 2 hours for zone 3. So we can perform any procedure like C-clamp. Here you can see angioembolization and extraperitoneal effect. So I think this deflation of the balloon is not less important than inflation because of this is collaborative work, because you need to inform all the participants, all the operators, anesthetists, nurses that you are going to deflate it, and we do it very slowly, not less than 3 minutes for deflation. So this is, for example, 3 milliliters. We withdraw every 30 to 40 seconds. So every time we record the time of balloon inflation to make a proposal for future reperfusion syndrome. So we can also repeat inflation if possible, if the circulatory collapse is developing. But after our couple of our cases, so we try to pull out the balloon as soon as possible. So sheath removal, different methods. You can see here we tried all of them except fascia closure. One time we tried to remove 11-French sheath with manual compression. We succeeded, but I wouldn't recommend it because of the large port catheter. Lateral suture, the most frequent method of sheath removal. So AVO sets can differ between institutes. We personally use what I described. This is a Reliant balloon. This is a table from well-known paper. So you just need to set all the wires, balloons, and catheters which are appropriate diameter. So what are the hazards and possible complications? So in adverent arterial damage, so I will show you a case. So if you would like to avoid such a picture in your operation room, so you should this sternotomy and book thoracotomy was caused by accidental perforation of a left ventricle by suprastick guide wire during stent graft implantation. Here you cannot see the tip of the wire. You should control it every time. And so here is an example how the simple procedure can be a very large, big operation with very high mortality and morbidity. So another one is inadequate balloon positioning. You should control it. This is zone nu, as I try to explain. This is my first attempt of first balloon in my institute. So fortunately, I injected only, so let's say 5 or 6, 7 milliliters of contrast medium, and nothing happened. But so I didn't see the balloon inflated on the cassette, which was below this level, and so that's why we withdraw all the medium and get it into the right position. So let's distal balloon migration is one of the most important thing. I will show this short movie about it. So this is an animal study where we try to show to our students how it works when we inflate the balloon without any appropriate support and with the soft wire. You can see here, and blood pressure is rising, the balloon is going down, and the shaft is kinked. Well, this is a case we discussed before about our patient with severe pelvic trauma, ABO in place. Our anesthetist were inspired by the effect, and so asked us to leave it deflated just in case, that caused severe limb ischemia and amputation. So another hazards are listed here. This is a balloon overinflation with compliant balloon. They're very nice, very fit to aorta, and it is difficult to damage the aorta, but you can damage another wall if uninvented catheterization of renal artery, for example, which is also not very often it can be done. Zone 2 ABO, I will show you during case discussion, this one or during the second case discussion. Reperfusion injury, you should inflate the balloon for limited time and deflate this as soon as possible. And I think puncture site problem is not very not a big deal. So we train all of our trauma surgeons to perform this. So we consider this not the simplest, but this is pretty simple procedure, and every trauma surgeon in our clinic can perform ABO. This is a very simple training machine, with a pulsatile pump, as you can see here, with a native ovine artery, that is aorta. But we also use grafts, PTFE grafts, for just to understand what is catheter, what is a wire, what is the balloon, how it works, because of no one in Russia from general surgeons or trauma surgeons don't know what is coil, what is gel form. So we should train them. So, and I will also show. I'll try to do it shorter. Should move about our military medical exercises. So this is annual exercises with we are modeling different injuries, transport the patient to from the field, from the scene, to roll to medical treatment facilities by these ambulances.
What happened?
So then we operate in tents. This we are modeling, and we operate in swine. So we do all damage control procedures to train our young residents. So, and also, last year was the first when we tried to implement rebore. So due to our colleagues from Tokai, they presented their balloons. Here we use 10 French introduced because the balloon was used a couple of times for training. So we size the length of the shaft, again the body, so moderate severe intra-abdominal bleeding, and then we have a portable X-ray. So just by means of this, we try to show to our leadership, so authorities, to leadership, that it is possible to perform the simplest and endovascular procedures in the field, in the military, so anywhere. So, and this also nicely demonstrates that how this one is for carotid blood pressure, and this is in contralateral femoral. So when we inflate the balloon, we show to our residents how it works.
You will be able to do it tomorrow in the lab.
Okay. So some conclusion that So we can see the ABO when we are in trouble, when I have an info from our coordination center in St. Petersburg that this is a severe trauma with hypertension. I put a cassette on the operation table, and I take this ABO set, and I'm ready to put the balloon in. Because of ABO is effective and relatively safe, and so you should be trained because of all the complications and damages demonstrated. We can see that it's effective at early phase when we put the balloon at during the first minutes when the patient is admitted, and we try to shorten the time of balloon inflation and withdraw the balloon as soon as possible. So again, this is a multidisciplinary approach, and we coordinate our actions with anesthetists, with vascular surgeons, interventional radiologists. All of them are included. So we having this team in the one step forward for success during the balloon occlusion. Thank you very much.
With the worry of lower limb ischemia and reperfusion syndrome, do you have quite a low threshold for performing prophylactic fascioscopies post aortic balloon? And do you see that as being part of a possible protocol for using it?
So we use it regularly in vascular trauma, but this case was terrible, such terrible that we're not leaving the sheath inside after this case. So this is our rule. We should take it out and then check if pulse or by Doppler or by just feeling a palpation. So we we try to avoid such a complications. So, but if you have a sign of limb ischemia, of course, you should first find the reason what happened. Is it thrombotic masses in the sheath, or it is prolonged thrombose? No, that's you should treat the patient accordingly.
Yes, please.
You didn't mention the Numet balloon, which goes from 8 French sheet.
Numet.
Numet.
Oh, I haven't heard about it.
Okay. So
There are some also in Japan, 10 French.
Yeah.
And I will ask Ishihiro to present himself. He's a representative for Tokai. They're very kind to help us in this workshop. They're our main help this time. And I would say some words, and then we will go through. Ishihiro.
Thank you, Tao, for giving me the opportunity to introduce ourselves. And I'm from Tokai Medical, a Japanese company, and we've been doing this business for more than 30 years. And our main product is IABP balloon, and the PTA balloon, microcasters, and neural protection device. And we've been focusing to domestic market so far. But as you know, the Japanese population is decreasing. So the Japanese market is shrinking now. So we have to find out another market in outside Japan.
Sweden!
So now we are now trying to get the foreign approval. And our microcasters just got the CE approval last year. So now as our microcasters is now available in European market. So now this is a second product for our target. This is a rescue balloon, and the biggest feature is a French size, and then most other companies and this kind of balloon, the seat size is more than 11 or 12 or 14 French, but this is a 7 French, actually 7 French. So you only need a 7 French seats. So this is one of the biggest features, and we are now trying to get the CE approval. I hope we can get the CE marking by the end of this year, and then this product and microcasters and these products is also available through our distributor Daniel and Mariel Medtech, and who's taking care of today's dinner. So If you have any questions, and please feel free to ask me or ask him. Thank you.
Great, thank you so much. And thank you for your help. Rescue balloon is over the wire, and also, I also saw the new competitors on the market, which have never been used on humans. It has great potential, and I think, as I said also to Ishihiro, there are some products we show everything that we can. The idea is medical to show you what's possible. Just one comment. We're talking again about the Reboa, but I think the major idea again is not the Reboa or the ABO. The major idea is the whole concept. When Rickard again is standing there and it's bleeding, and then he can call Artai to come in. So Hani is not here right now, but the idea is you get the bleeding, you open, you do laparotomy, it's massive bleeding. Let me remind you, nobody is working on the femoral artery. Nobody. In most of the cases, in most of your institutes, I can guarantee that nobody is working there. So you can use this parallel, and you can use it in some really challenging cases. One of the cases when mentioned by Thomas is Anna Lind, vena cava injuries, or there is at least potentially, and this we tested in pigs, to put a balloon in the venous system from down and above, theoretically. I'm not saying it's possible, I'm saying theoretically. There are a lot of tools you can use to help Rickard when he's struggling with this huge bleeding. It's only Rickard that does it.
Only I have problems.
Yeah. Okay, let me comment now. The rest of the surgeons don't have problems. No, but the idea is that it's important tool. And the only way you can use this tool, if you put the patient on a sliding table. If you don't put him on a sliding table, you're limited again. And this can be a major advantage. And that's why we have Stila here with their tools. And of course, the C-arm that you can just bring into the room when you get problem. Even in iatrogenic injuries that we did a lot of times with pancreas like surgery, the patient has bleeding.
Rickard did that.
Yeah, no, it was Rickard's fault. No, but these kind of things, we solved a lot of problems this way. So it's another tool. I would suggest we take some minutes to breathe from all this Reboa thing. And then we do like this. We will do some groups. And I will ask Linda, Abdullah, Yussi, Mirigani, Uwe, and I'm not sure Garrett D, if he's here. Yeah, because Williams is here. Okay. To go to this table with Victor, Martin, and Rickard. And there we will work, and then I will say the rest. And Mikael, Ahmed, Hani, Johnny, Mariella, if she's here, Sammy, Per, and Yunus will go to this table, and the rest will go to these stations, and I will help you to rotate. What we will do is like this. The idea here is to discuss the materials, the procedures you can do, what to use, how to use the equipment, just generally. Then working with the C-arm, the sliding table, the access. You can puncture there. You can do a Saldinger method. You can puncture it. It's a dry model. And this you can puncture several times. This is built by 3D. And you can use it and you will get in the rescue balloon. We have also the other products there, and we will show you. And later on, you can see also other products like coils, like Onyx. The company is here and can show you, and you can speak to them and get a bit more information. And did I forget something? And of course, with the balloon. And I think it's worth to try also partial occlusion. Just to understand partial occlusion or partial Reboa, you take up the balloon. If you have invasive blood pressure or you have a pulse here, you can keep the patient alive but not fully inflated. It's very hard to do, and you don't know if you succeed, but there is a point in it to get perfusion. It's done in very few cases. We published one. Yuri has done several like this in our registry. People done it. Victor did one. So it is doable. We don't know if it's good or not, but it's doable. We will train here on ultrasound. Per will help. How to think with ultrasound, how to do. You don't get to be a master of ultrasound in 20 minutes. This great simulator, you can train to put the Reboa and do embolization. And then we'll try to rotate because I think it's important to hear what Martin is saying and then hear something maybe else from Thomas and other views. How do I work? How do I think? How do I hold it? I don't think there is some absolute truth. There are different ways to do things. Is it clear, more or less? Okay, and try to help me. If it doesn't function, tell me. Let's do 5 minutes just break and then continue. And the cases will come in around 1 hour. We do a break and do cases. Okay?
Where is the OR here? Something is going wrong.
Oh, it's very fun. Yeah, let's take them down there because we will sit down. We don't need so many. Nina, kan du öppna TSQ?
Den går ut och så går man förbi den här skärmen.
Jaha. Ja, vad bra.
Gilad?
Ni måste också just nu ser jag som Kjell säger, de här det här med CT, det är ett problem som man har. Ja, vi såg ju det. Det gör det. Det är live. Det är ju live. Men EVTM, det här drar lite mer på sig. Då har vi 3 ämnen som ska välja. Så kör vi 10 till